Good morning, one and all. Myself, Dr. Anita Venugopal. I bid a very warm welcome to all the renowned speakers, panelists, and delegates who took out their valuable time and joined us today to be a part of this webinar. First, I request Dr. R.K. Sir, Advisor, Aravind Eye Hospital, Tirunelveli, to speak a few words.
Respected Dr. M.S. Sir and dear invited faculty and our own Aravind faculty and friends, very warm good morning to all of you. At the outset, I like to extend a warm welcome to all the guest speakers, my dear friend Dr. J.K. Reddy and Dr. Radhika Tenten from RP Center and Rohit Shetty from Narayana Ectasia, Bangalore, and also our own faculty from Dr. Revedi, Anita, and of course people from other Dr. Seema, and all the Kanya people from our own institute. And also you have to, because for the past 3 months, Dr. Anita was doing a wonderful work in coordinating this Kera Ectasia. I was also wondering why Kera Ectasia is such a only keratoconus and some other eclectic condition. Why is this? This can some infective keratitis and other things made together. But after seeing the program and this thing is much more. This is one of the fastest growing field in the field of cornea. So much of developments in these last 2 decades in the keratoconus and other corneal eclectic conditions. So is and also I'm very happy that the faculty who are going to deliver the lecture under the leadership of Dr. MS is they've done wonderful work in the field of this condition for the last 3 decades. So definitely it will be a wonderful scientific feast. And also I'm very happy that, and also congratulate Anita has taken this and done a wonderful job of organizing this webinar on Kera Ectasia. Thank you very much, and I once again welcome all of you. Thank you.
Thank you, sir. Thank you for the beautiful words, sir. Thank you. Coming to the introduction. So we are honored here to have 2 of the 10 best eye doctors, title holders from Outlook India for this session with us today. First, we are fortunate to have that, I would say, the best teacher among us who would show where to look and not what to see. A good teaching is more like giving of a good questions than giving a right answers. It's a honor for us to welcome Dr. M. Srinivasan sir, Director Emeritus, Aravind Eye Hospital, Madurai, as a chairperson for our session. He has been listed among the top 2% scientists of the world by Stanford University. You're the best because you brought out the best in every one of us, sir. Thanks for joining us. The next Outlook Best Doctor title holder, Dr. Rohit Shetty, Vice Chairman, Narayana Ectasia, Bangalore. He is one of the high volume refractive surgeon. As far as I know, sir enjoys himself speaking about corneal imaging. Most of his publications on corneal ectasia has been well received. It is a moment of extreme pleasure for us from Aravind Eye Hospital, Tirunelveli, to welcome you both for this webinar. Now, I would request Dr. M.S. sir to speak few words on overview of corneal ectasia.
Thank you, Dr. Anita. So I don't have any slides to project. See, all these years, cornea means infective keratitis and keratoplasty. And recently, I don't know why I could not find out, because every day morning when I sit in the OP, first 6 or 7 patients, at least half a dozen young patients, mostly school-going, college-going students, first time reporting with the defective vision, and we diagnose keratoconus. So why we see so much, whether the incidence is increasing because of the booming video games, or we are picking up early cases because of the modern biometers. That's the one thing. And then still there is a gray area about how to define the progression of cataconus. Suppose we see a patient this year and it is about Steve 48 diopters or something, early cataconus. And how do you assess the progress? The reason is, yesterday I saw a patient, she was about 21-year-old. She is having a pentacam since last 2018. Every year she has pentacam. She appeared as a candidate for interview with the testimonials. So many, she is carefully preserving it, and there is not much difference. So first you should, experts like, see, Lohit Sethi is, cataconus, he is doing a lot of work and he is like an authority, and Raja Tandon would have seen so many patients. And you should know which is cataconus and which is with the rule of stigmatism. So these patients, since 5 years is coming, there is no change in refractory error. Axis 180 degree cylinder, and but faithfully she appears to you because you ordered pentacam every year. And their corneal thickness in some patients with the rule of stigmatism, it is more than 500 micron, but some cases it is 470, 480. So now you have to confirm it, whether it is really cataconus or something else. So, but I say these patients, it's not cataconus, it's with the rule cylinder, it won't increase, you just have glasses or contact lenses. Then another thing, now unfortunately we have so many gadgets like that. So we had topography, then we had tomography, then you have OCT, now you have epithelial mapping, and how many equipments you will have. So some of the referring doctors, they have the old one, topographies, and then they refer to you. And last week I saw a patient with epithelial mapping, epithelial thickness mapping, done in Chennai somewhere in a top hospital. And then our doctor asked for a pentacam because they have referred here. And the epithelial mapping, the cataconus area, the epithelium within, and the donut appearance, all these things. But it's totally different. The cone isn't different. It was lower temporal. The epithelial mapping shows cone in lower nasal. So which is correct? So do you need epithelial mapping in all cases to pick up early cataconus, subtle cataconus? And this mapping, now they are putting a lot of significance on this because you are all refractory surgeons. You do LASIK, you do PRK. So how will you confirm that this patient doesn't have any pre-op subtle cataconus or prone for cataconus? So that's also very important. So now, young doctors, you can't avoid, you can't escape from all these things. Tomo, and you can order the test, technician take the test, and they bring the map to you, and you are the one you have to confidently pass the message to the patient you have or you don't have. That is very important. Then, what is the incidence of Kera Ectasia after refractory surgery and after CXL, collagen crossing? That also variable. Kera Ectasia was common in 1998. Theocyted first reported Kera Ectasia post LASIK. Then initial days, because we had only pachymetry, manual pachymetry, ultrasound pachymetry, no tomography, no OCT. So we missed a lot of subtle cataconus. So then the incidence was about 0.22 or 0.6 like that. So now the recent report, they say it is about, still it is 1 in 2,000 cases. And the recent one, the report yesterday was reading, out of 5 cases, 4 the patient had pre-op cataconus, subtle cataconus, they missed them. So now they are able to pick up. So then CXL ectasia, especially pediatric catacomnus. What is the progress after CXL? So they say, some people, they say it is 10% or 9%. So that also you have to tell the parents, now the parents are so anxious, single child, well fed, obese, tall, they all come with a catacomnus and they are really scared. They visit about 2 or 3 doctors. For heaven's sake, don't pass the message to the parents. If you don't undergo CXL, the cornea will rupture. This is what they get the message. Next day morning, they land with me, and then it's very difficult to convince. Very rarely you may get hydrops, rupture. Very difficult to convince. So you can put a word that it will be progress. It will progress. So the current technique is cross-linking. It can arrest the progress, but it will never recede, never go back. Lifetime you need glasses. These things, they are happy to hear that. So then, when will you order? So now all the recent reports, they say that once you confirm catacomnus by tomography, and immediately they suggest C3R. I agree with them. I don't want to wait, telling the patient, you come out 6 months, you repeat the pentacam, then if it is increased, you'll do that, like that. So it's not, you don't have the definite definition for progression. Some people say more than 1 diopter, refractory error, thickness less than 10 micron difference, like that. So I now am really convinced, not much complications after CXL. And so if the cone is about 50 diopter cameras, like that, if you confirm, I just tell them, go. So I don't wait for 6 months. So if you are really convinced that this patient is catacomnus, I will go ahead. So then, one thing about VKC and catacomnus. I think Rohit Seddy is doing a lot of investigations. They order vitamin D level, all those things. So these people, rubbing you can't avoid. Whatever medicines, they will have rubbing, and what will you do? Well, do C3R and continue anti-allergic medicines. That also we have to discuss today. And then the last one, keratoglobus. So 3 weeks back, I had 2 patients, one mother and daughter. Mother had keratoglobus, undergone CXL at Trichy. Then they sent the daughter, 9-year-old, with keratoglobus because she needs general anesthesia. They are referred here. I think keratoglobus is congenital, and they don't need CXL. Unnecessarily, they have done CXL to the mother. So pellucid, okay, controversial. Pellucid you can try. Keratoconus you can try. And post-refractory surgery ectasia you can try. So there's a lot of things, and priority will be when you call it as a keratoconus, going through various tomography, epithelial mapping, and when will you start the treatment, and how will you address the progression of the keratoconus. These are the things. Today's discussion, you have all the top people, and you please discuss, and because it's very important to deliver the message to your juniors as well, because so I am not interested in seeing keratoconus morning 9 o'clock first case. So that is for fellows, and technician will do the mapping and fellows will then you do that. So you may be best person to diagnose and manage. But you have, like Radhika has so many assistants and fellows, residents. And she should confidently pass the message, this is it, this is what you do. And that should be carried out successfully for future generations. So I once again thank Anita and all the faculty people joining us, and thank you very much.
Thank you, sir. As I said earlier, sir has put forward right questions to us, and we have to find the right answer for it. Was again a great pleasure, sir, for listening to your wonderful thoughts. And thank you, sir, for sharing your expertise. Next in our panel, we have our esteemed speakers. It's again a great honor and proud moment for us to welcome Dr. Radhika Tandon ma'am, the Professor of Ophthalmology, AIMS, New Delhi, who hardly needs an introduction. Her achievement and knowledge are endless. A warm welcome, ma'am. We are grateful to you for accepting our invitation at a very short notice and honoring us with your presence. Thank you, ma'am. Wisdom is not a product of schooling, but of a lifelong attempt to acquire it. Quote by Albert Einstein. Lifelong attempt to acquire knowledge, to discover newer procedures, and the eagerness to find new treatment for corneal disorders and working towards connecting young minds to strive towards success and achievement is the amazing uniqueness of our renowned speaker, Dr. J.K. Reddy sir, Director, Kera Eye Hospital, Coimbatore. Welcome, sir. Next, we have Dr. Revati ma'am and Anita ma'am from Aravind Eye Hospital, Coimbatore. They are wonderful and true teachers. I have developed interest and passion for learning cornea only from them. They have awakened the love of learning by their own reflected love and sincerity towards the field of cornea. I welcome and thank both of you for joining us. Also, I extend a warm welcome to Dr. P. Mangala, Dr. Josephine Christie, and Dr. Seema Ramakrishnan, having joined us as panelists for this great event. I guarantee the delegates, your next few hours will be delightful and memorable with lots of learnings and discussions. Without delay, I would request Dr. Aditya Gorpade, Consultant Aravind Eye Hospital, Tirunelveli, to moderate the sessions. Thank you.
Good morning, everyone. Myself, Dr. Aditya. Let us start the session we are all waiting for. Few things to note just before we start the session. For the smooth presentation of the speakers, we have muted the audience. Kindly put your queries in the chat box. We will try to take up the questions after each talk. Without further delay, let us hear from the experts. I would like to invite Dr. Revati Madam, Head of Department, Cornea and Refractive Services, Aravind Eye Hospital, Coimbatore, for the talk on genetic controversies divulged. Madam, over to you.
Thank you, Aditya. Hope you are able to see the slides.
Yes, ma'am.
Yeah, I'll start with the thing. I want to thank Dr. Anita in a sarcastic way for giving me this topic of, sorry, it's not moving, sorry. Yeah, the genetic controversies of, in keratoconus, because, I'm not a very theoretical person, and getting this topic, I got totally overwhelmed. But at the end, I really like to thank Dr. Anita, because I learned a lot by working on this talk. And of course, the way she put it, it's more colorful. But basically, like what I am going to deal is also about etiology of keratoconus. So the etiology of keratoconus during my course of this short course of my being a cornea person, it's evolved a lot. So initially when we were PGs, it was considered as a kind of a degenerative condition because it's non-inflammatory, some kind of a disorder which affects the corneal shape due to thinning and protrusion. So nobody knows why this is occurring, and so it was put under degenerative conditions. This PMD and TRNs, everything classified as degenerative. Then later, we started, you can see in the old textbooks, like it started considered as a dystrophy. This PMD and keratoglobus as part of different manifestation of a particular dystrophy, which affects mainly the corneal collagen and causing thinning. Because it is bilateral, there is some heritability because some familial incidences were noted, and genetic mutation, especially sporadic mutation, was found out by the time, and it is considered as a non-inflammatory condition. Then later, of late, there are a lot of molecular level work shows some kind of inflammatory reaction also in this condition. So finally, it now considered as complex interplay of many environmental and genetic factors, and it is a biomechanical and biochemical disorder. It's now being considered as one of this. And is it a genetic disease? Why we are thinking that it could be a genetic disease? Because varying prevalence is seen in different ethnic groups in the same locality. If you take particularly like metros like London or something, the Asian population will have more incidence than the Caucasian population. That shows there is something due to the ethnicity. They are more prone to develop the disease. And also the familial inheritance of late with the better diagnostic techniques is reported from 13 to 21%. It can occur in families. And then the monozygotic and dizygotic twin studies also being conducted in this disease. That this is the best way to know whether a particular condition is having genetic predisposition. So the discordance and concordance has been studied, and then again it is more showing to us that it is a genetic disease. Then it also is being noted associated with many other genetic disorders, like general genetic disorders like Downs, Marfan's, and also with the local disorders like ocular disorders like corneal dystrophies. And also noted with some connective tissue disorders, which again may probably have a genetic predisposition, like mitral valve prolapse and brittle cornea syndrome and other things. So the twin studies, as I mentioned, it is of it's very interesting. If a particular disease is showing concordance, that is both twins of the monozygotic twins, both candidates, if they have the disease, it is more towards the genetic origin because they share same genetic message. But if at the same time in the dizygotic twins, the same disease is showing discordance, that is, it is not both candidates are not affected, then it is more towards genetic disease. That's what been so far noted in this particular condition. But at the same time, even in the monozygotic twins, there are instances of discordance. That is, only one of them got affected, not the other one. So that shows that there should be an interplay from the environmental trigger factors also. So that also we have to keep in mind. Then what is the problem in identifying a particular gene or a particular area that this is the reason for this if it is a genetic disease? Though it occurs in families, its clinical expression is variable. So in the same family, it may not be all of them will have frank keratoconus. As Dr. MS put in, like some of them will have frank keratoconus, some of them we have to diagnose only with topo or other recent imaging techniques and biomechanical strength testing. There are many other things still evolving. Still, we can't say that we have found out a comprehensive test to clearly know that this cornea is having keratoconus or it is having the tendency to become a keratoconic cornea. With all these newer diagnostic tests, now we are able to find out more and more different stages of the disease, some of them completely subclinical. And because of that, now we know that we are able to see the candidates in the family to find out that this is a familial disease. And also we noticed that 20% of the patients seeking the refractive corrections, whom previously considered as only refractive errors, now we know that they are having keratoconic tendency. So we are advising them not to undergo the procedure, as this again pointed out by Dr. MS. And then because of all this investigative development, Rabinowitz and others projected the genetic possibility is about 50% from previously considered 19%. And they also noted in a family, the cone pattern morphology is also almost similar. Though the disease expression is different, the cone pattern, once they develop keratoconus, the cone pattern, either a nipple cone or a central cone, it's almost similar in a particular family members. But this has to be validated with further studies. So then coming to how we can identify the genetics of the keratoconus, the most common type is sporadic, as we know. Autosomal recessive pattern and dominant pattern are also reported. And as I told, phenotypic incomplete penetrance and the phenotypic expression also is highly variable. And that is why it's very difficult to even like define a study population and then study them. And this problem of defining the study population is now being addressed by the newer diagnostic tests, as I told you before. So when we are doing a molecular genetics to find out a genetic component in a suspected disease, they will do it in different ways. One is identifying a particular candidate gene. This can be done if a particular only one cause for the particular disease, like absence of an enzyme or dysfunction of an enzyme as an inborn error of metabolism. Then we can go and look at the particular gene which is responsible and find out whether there is a mutation or something else in that condition. But this is not the case with keratoconus. So the other one is linkage method. If we know that this particular disease is associated with other diseases where we know the genetic origin, then we can go to the same genetic region of the chromosome and look for any new gene location or any modification. So the association can be found out, and then we can say this is also a genetic disease. This again, this is not a foolproof method. So the recent one is a hybrid of this both. Don't ask me what is how to elaborate. This is above my head, but to a certain extent, I can say that a small population sharing a same ancestry, like even in India, we have some populations where the consanguineous marriages and other things, very little mingling with outsiders, will have more genetic similarity and they will show more genetic abnormalities. These are the good study populations. And then by doing a gene mapping, we can find out some of these difficult diseases like this. This is what now being tried in the genetic field. So one of the candidate gene they were looking is any gene which is related to collagen, because we know the collagen is wrong here. So they looked at the collagen genes, but at least they could find out some of these genes are not related to or not causative genes. Only that much we are able to find out from these studies. But there are other genes which are related to even the inflammatory mediators also are being studied. And two of these genes, one is TGF-B1 and also the gene related to brittle cornea, they are under consideration. And there are many other, the recent one of the articles showing another handful of such genes which are being studied. We may get some information in the near future with them. So coming to the candidate gene, there are two genes where initially other two candidates, candidate gene, because they are related to linkage method, they are related to other known genetic disorders which are known to be associated with keratoconus. One is the superoxide dismutase, which is more seen in trisomy 21. The other one is the VSX1 visual system homeobox. But this one is more seen in corneal dystrophies. That's why it's being studied, and it is found to be the studies are not supporting a role for this particular gene or the related location for the keratoconus. But the first one, SOD1, is still under consideration because this gene is one which is giving protection for from the oxygen toxicity. So keratoconus or any cornea, any disorder which can be because of exposure to constant UV radiation and other things cause inflammatory this thing and reactions, and also the oxygen toxicity protection is not there in this individual, they might develop keratoconus. So this is still under consideration. So the other linkage, chromosome 21, as I told, already being studied, chromosome 17 in Leber amaurosis, and also chromosome 13 in some other collagen disorders. These are all under consideration again, but again, as I told, not yet clearly understood. And coming to the locus, there is one study which studied in 27 family members, who have shown prominent expression of keratoconus, and they found out a new locus. But the problem, because of the variability in its expression, this particular locus may be true only for this particular family. So that may not be, if you look up for the same locus in the other ethnic people or other family members, it may not be there. So this also we have to keep in mind. And coming to the other associated genetic disorder, we know a large number of disorders are there. And in the first three, Down syndrome, Leber's, and atopy, we are still not sure, is it only the genetic component? And we know that eye rubbing, eye pressing is there in these conditions. And this also could be playing a role in the development of the disease. And other connective tissue disorders are also there. One thing which of new information, which is very interesting for me, mitral valve prolapse was noted in one particular study in 44 to 58% of keratoconics. So this is, I'm not aware of. Only if I see the patient is having a Marfan-like features, then we used to go for. Many of them are undergoing even DALK under GA, but we have not noted this so far. Maybe we have to look for it very carefully now. The eye rubbing, as I told, in many of the, even the genetic, supposed to be genetic connections, we know this eye rubbing is a main problem. And we know now they elucidated this, why this eye rubbing could be the reason, because these keratoconic corneas are more prone for, their keratocytes are more prone for apoptosis. And then like, and in the, this is seen by Kim et al. In keratoconus, 60% of the corneas are showing apoptotic keratocytes, when comparatively 0% in the normal people. And why this apoptosis occurs? Because these keratocytes are having more number of receptors for inflammatory mediators like IL-1, which can be released by eye rubbing. And that is why some candidates are more prone for developing keratoconus or fast progression with eye rubbing than others. So another another interesting finding, when a lot of studies are done in Down syndrome, Hashmi et al. Found out the keratoconus in mothers who are having Down syndrome children, when it is compared with keratoconus with the mothers who are having normal children, they found out the collagen abnormalities, especially thinner, steeper corneas, are more seen in the mothers with Down syndrome than with the Down syndrome children than with mothers with normal children. Though both group is having keratoconus, but this collagen abnormalities are seen more in mothers with children of Down syndrome. So there should be some connection here. So the other possibilities are sunlight exposure. We will be, of course, due to oxidative stress, but we will be surprised because UV radiation is considered as a treatment for keratoconus for the collagen cross-linking, but in otherwise it can also be a triggering factor. And hormonal effect also is being reported, especially we see clinically in puberty and pregnancy, a fast progression in even in the subclinical keratoconus being getting unmasked. This also we are noting, but the exact way how it is being done, we don't know. And the diabetes is a good thing, like because diabetes is giving a protection. If we because incidence of keratoconus is very less in juvenile diabetics, even if it occurs because of abnormal glycosylation which occurs in this corneas, it might be protecting, the progression will be very, very less in diabetics. So in summary, the genetics is still alluding for conclusive understanding, but with our advanced diagnostic method and genetic studies, we may find some answers in the near future. Now we know there is some genetic connection, but still it is not very clear. There are many other factors also will affect this disorder, not only the, especially lifestyle. This we have to keep in mind. Off late, with the lockdown and online classes, a sudden deluge of keratoconus and even myopics we are seeing. We don't know what is the effect there. This need to be studied further. Thank you. As our chief used to quote, much has been done, but much remains to be done in this area. We look forward for the future with enough renewed strength. Thank you.
Genetic aspect of the keratoconus is less ventured in the discussions in contrast to clinical features. Thank you, madam, to explain the intricacies and giving us a new outlook in what conditions we have to actively look for ectatic disorders, even mitral valve prolapse. I would like to ask inputs on this topic from the speakers and panelists. Audience can ask questions in the question and answer box and chat box. Thank you once again, Madam, for interesting talk, Madam.
Thank you, Aditya, for giving me this opportunity.
Genetics was made simple by your talk, ma'am. Thank you. Actually, I had this in mind for you, for giving you this talk, because recently we had a patient, ma'am, 24-year-old female with a primary amenorrhea with a progressive keratoconus. So we were like surprised to diagnose in that patient after the Ogesian's referral, everything, Mullerian duct anomaly in that patient with a hypoplastic uterus and septate vagina with normal ovaries, but her the sex hormonal levels were high normal levels. So like when we researched in the literature, we found that some VNT signaling pathway that is commonly associated with both these conditions, with the keratoconus and the Mullerian duct agenesis. So like noting, like if we see like new things, like it is very interesting to note that genetics also plays some important role in all these conditions. And even we are now seeing noting progressive keratoconus in after 30 years age also in a few of our patients. They are like recently they are increased the incidence of those patients. Thank you, ma'am.
Actually, when I was going through, there was one nice line. Keratoconus can be the final pathway, common pathway for many of the conditions inside what is going on in the body, genetic, hormonal, and many other things, inflammatory, and many associated syndromes are being reported also. But we don't know why this is like PUK. Exactly why they are all manifesting as keratoconus, that I think still we need to know.
We have a questions in the audience chat box. How much helpful the genetic screening is for the keratoconus? Still, I think the question means until how much degree of sibling we have to look for actually in our practical experience.
Yeah, practically, yes, we have to. It's better to screen at least the siblings. I mean, as I told, as MSR also pointed out, it may not be only clinically manifested keratoconus, so it may be even subclinical. One thing we notice, like, one person is having keratoconus. If the sibling comes for refractive surgery, even if the screening appears okay, generally we advise not to undergo, because there is a possibility, definitely. So that is one area where we have to be very, very careful.
What would be the causes for unilateral keratoconus, ma'am? We have a question in the audience.
Yeah.
Like,
again, as I told, unilateral maybe clinically, subclinically the other eye also in future it might show. That we have to wait and observe. Absolutely unilateral in an adult maybe of 40 years or more. So far I have not come across. If it is there, then it is of interest that we have to. But there are some conditions. See, in acne rosacea, you can have ectatic cornea, like something like a keratoconus can occur in the area where the inflammation is going on. That may be a uniocular one. In interstitial keratitis, we can get something like that. So that is also possible, that we have to habitually lying on one side or rubbing one eye, that we have to see.
Yes, ma'am. Yes, ma'am. That was such an interesting talk that so many questions are coming. Actually, we have one question as, are there any labs currently offering any genetic testing, like where should we look for? Anything you know of, madam?
Yeah. As I told you, still we don't know how to test. Coming to the practical level, they are all in the research level only. Still they don't know, unless we know a particular area or a particular candidate, microsomal or a gene candidate with which we can associate keratoconus, then only it will come to the level of clinical application. So now it is in the research stage only, so we may not be able to do that screening. But we know diseases like trisomy and others, we have to look for keratoconus and we have to keep it in mind.
For this patient also, which I was talking about, that patient, I had written a case report on that patient, and but the authors, like the reviewers, comments were like, you have to make have a genetic link association should be made for this case report to be published. That was their comments in that. So when I was searching for it, in the genetic labs, everything, they wanted to have some tissue which is very much near to that of the disease. Like they wanted an endometrial sample, something like that, to find out the association. Corneal epithelium is easier, but getting the tissue from the other sources is a little difficult. Thank you, ma'am.
We have other questions in the audience also regarding the scleral contact lens, CXL and grafting. We will take up the questions as the talk comes. Let us move on to our next topic, unveiling clinical and topographical features of ectasia. Dr. Anita Raghavan, Madam, Consultant Cornea and Refractive Services, Aravind Eye Hospital, Coimbatore, is here with us. I'll hand it over to Madam. We have a pre-recorded presentation that will play now.
Good morning, everyone. I'm sharing my screen. Is it visible?
Yes, Madam. It is visible, Madam.
Okay. So at the outset, I'd like to thank Anita, Dr. Srinivasan, and everybody at Aravind Eye Hospitals for inviting me to participate in today's webinar. This is indeed a very important topic, and as everybody has indicated so far, there is quite a bit of confusion going on in certain aspects. So it's and the way this program is organized, that is also very nice, that adequate time is being given for the topic to be addressed and then for discussion. So it would have been nice to have Anita's talk before me, but since it's an area that people are already familiar with, so I think I will not go into too much details about the preliminary bits about the diagnosis. I'd like to mention that here I'm going to talk about surgical options for advanced pellucid marginal degeneration and keratoglobus. The topic being so vast, it is very difficult to cover everything in a short time. But it is a little challenging situations that we are needing to highlight, because all over the country, there are so many CMEs and webinars going on, that basics of how to manage and, the routine cases, that is more or less being covered in most forums. Just a little bit of information here. Now, when you look at advanced PMD and keratoglobus, now you think about PMD, you think of keratoglobus, they seem like very distinct entities, and for that matter, keratoconus as well. But honestly, you will often find patients, and as Anita mentioned, that you'll find a case which is unusual, and though you may have read up everything, you may have attended any number of lectures, but the patients are the ones who will have some unique feature, and it is these individual cases that one has to look into more detail to help a better understanding. So just to explain, it seems simple, but often it may be complex. And if you really want to know what it is, whether it's a PMD, keratoglobus, you really have to take time and go into the patient in detail. Generally, they are bilateral, but definitely one will see asymmetrical cases. Somebody had asked a question about unilateral keratoconus. So yes, sometimes you will find atypical cases, a lot of asymmetry and involvement. One eye may be very advanced, the other eye may have very subtle features. And here again, this is because of the various etopathogenesis involved. So it may be that one particular eye, the patient has a habit of rubbing that eye, or some other inflammatory parameter may be more, or some factor may be responsible for that particular eye to have moved in such a way in one direction compared to the other. So they're both bilateral, and they are non-inflammatory in the traditional sense of the term. It's not that there is, as we know, that there is an inflammatory component for triggering the disease and progression, but that is, this is the traditional concept of non-inflammatory, where you have an active inflammation, a painful red eye, or an active infectious pathology which is leaving it. But there is, of course, subclinical inflammation, inflammatory markers in the tear film, etc. So therefore, this is like a sort of a clinical aspect of non-inflammatory, that usually the disease, when it is developing, is not because of an active inflammation, which is visible with the traditional symptoms and signs of inflammation. Of course, there is ectasia. And here, this is the point which Dr. Srinivasan brought regarding progression. Generally, keratoglobus is a sort of inherent disease which is there from birth or in early life. And generally, it is not very markedly progressive. Once it's there, it's there. Whereas the PMD can be progressive. And regarding the protrusion, in keratoglobus, it is a typical globular protrusion, limbus to limbus thinning. In PMD, even in advanced cases, you may mistake it for keratoglobus. But if you look, the thinning and the protrusion will not be uniform in contour or over the full 360 degrees of the cornea. Similarly for the thinning, whereas in keratoglobus, it is more uniform. And here it's also important for the younger people, because if they're taking exams, if they're going for MCQs, if they're in the beginning stage of their career when they have to diagnose a case, somebody's asking them to differentiate. So these are the little nuances that you need to think of to differentiate. And of course, acute hydrops can occur in both, but in keratoglobus, largely, if you do have a rupture in the desmos, it can be very extensive, there can be a huge rip in the desmos membrane. And then there can be associated features. Of course, in PMD, there could be a combination of keratoconus and PMD, and keratoglobus may be associated with scleral thinning, and keratoglobus particularly is prone to rupture. You had a discussion earlier on how patients coming with keratoconus, the doctor should not tell the parents that if you don't go for cross-linking, the eye will rupture. And then on the other hand, you had a patient of keratoglobus who had the cross-linking done. It's important to understand that keratoglobus is particularly prone to rupture, but the prevention of that rupture is not cross-linking. The prevention is counseling and education of the patient and the family to avoid trauma at any cost. So they have to be very, very vigilant about eye protection. So having come to that, this is all the differential diagnosis, whether you put one above, one below, it's all mixed up. And if you have a very young child coming, or maybe in the first year or two of life, sometimes you may even have a confusion whether it's a case of congenital glaucoma, because largely the eyes look very big. Then there is congenital megalocornea. In here, the cornea is large in diameter, intraocular pressure is normal, but there is no thinning, and there's keratoglobus. So here again, these are all the conditions which will come into your mind depending upon the clinical presentation, the age of manifestation, and the features of presentation. If you see in this picture, this is also very advanced case, but you can see there is a distinct thinning inferiorly, and the ectasia is presenting above it. Whereas in keratoglobus, there will be a uniform thinning limbus to limbus, and it is easy to differentiate. But if you have very advanced PMD, and sometimes they may come with a lot of irritation, they may have acute hydrops, and at that time it may be difficult to differentiate. When the eye settles down later, you can distinguish. Now coming to technology. Technology is a real boon and a bane. But certainly when you have a patient of pellucid marginal degeneration, you get this sleeping bow tie pattern. Whereas with if you have a PMD with keratoconus, again, it may be a very different pattern. It may be very irregular. And when you get a keratoglobus, there is a thinning, all global thinning. And as you can see, this image of the pentacam is very useful to detect it. So depending upon the case, you have to use a appropriate tool with the machine to help you differentiate. Now, what is the goal of treatment? Now, here again, I would say whatever you do in any of these patients, you must always indicate eye protection, because even if they're not going to rupture, but PMD and keratoconus, is very rigorous rubbing can induce an acute eye drops. And in addition, of course, we all know that rubbing and pressing on the eye can also lead to progression. So that is important to counsel depending upon the patient. Then the visual rehabilitation, and then the surgery. Now, what is our surgical options? I was asked to give our experience. So I'd like to talk about our experience. And largely, I would say for these conditions, the aim is lamellar keratoplasty. There are definite advantages of lamellokeratoplasty, and these diseases, unless there has been a very severe hydrops and an extensive damage to the endothelium or scarring, largely anterior lamellar keratoplasty is a very good option. But yes, in decision-making, case selection, which surgical technique, and look at the presence of comorbidities. This is all very important in decision-making, not only in the type of surgery, when to intervene and how to intervene. So you have to take into the patient's age, the requirements. Like, for example, there may be a person who's studying in class 11 and about to take the board exam, whereas another person may have finished all the education. So all these things need to be taken into consideration, because we, the doctors, know what is going to be the trajectory, but the patient's family do not often know. They may not realize that they go for the surgery and then the rehabilitation and repeated visits to the hospital may take some time. So this is something that they need to be counseled, because there will be repeated visits, suture removals, and it's not that the vision will come back like magic immediately. So all of this needs to be taken into account. So whether to do operate or not, what is the plan, and then counsel the family so they are properly aware of what is to be expected and anticipated. So when we have, so these of course are the game changers with keratoplasty, and I'm mentioning posterior lamellar keratoplasty again because sometimes you may have a situation where you may decide to do an anterior lamellar keratoplasty first and then do a posterior endothelial keratoplasty or endothelial transplant later on, or you can just go for a straight head full thickness penetrating keratoplasty. So it will all depend upon what is your goal, what is the time that the patient has, how much is the vision, and how much you want to give back immediately, or whether you have some time. So as I said, don't trivialize keratoplasty. It is not without complications. Very, very, very rarely you can have a terrible infection with the donor cornea, because after all, it is not a sterile tissue. It has been decontaminated, but the very, very rare risk of actually getting endophthalmitis. And that is something which should always be at the very back of your mind. And of course, if there are patients have had repeated attacks of inflammation, they sometimes have infection, and so therefore they may have deep vascularization. There may be other risk factors for graft failure, and any condition needs a detailed evaluation. Supply of donor tissue in that context, I feel that whenever you can do an anterior lamellar keratoplasty, it's always a good use of donor tissue, and it's also better for the patient if their endothelium is healthy and they're less at risk of getting an endothelial rejection and loss of graft clarity due to immunological rejection. So you have to decide whether to graft or not and choose a procedure most beneficial for the patient. Now coming to advanced, now I would like to combine the approach to advanced PMD as well as keratoglobus, because practically we're talking about very advanced cases. If it's earlier cases, you can do partial surgeries, you can do eccentric surgeries. But I'm saying when it's very advanced, these two conditions are practically considered the same, because the lesion is leading up to the limbus and you have a very ectatic cornea which has to be tackled. So this is a procedure which was described by Dr. Vajpayee when he was working at RP Center, and the cornea team had at that time prepared animation to explain. So it is called tuck-in lamellar keratoplasty for corneal ectasias involving the corneal periphery, and this basically involves a 360-degree of just inside the limbus. You do a trephination, a partial thickness donor, a host cut, and then you do a lamellar dissection to make a pocket. So this was at the time when we were doing manual surgeries, and using a blunt dissector, you make a host pocket, and then the donor cornea is virtually almost the entire diameter of the cornea is used just inside the limbus. And in the periphery, since we are tucking it in, the tissue has to be thinned in the periphery. So you make a little bevel by cutting out the peripheral rim of the cornea from the endothelial side, and then you insert it and tuck it, and then you have to press it down. Now, sometimes if the cornea is very, very ectatic, as I will show you in the surgical videos, this step can be a little difficult because it's very difficult to press it down. The sutures may cut through. You may have to use a triple throw suture knot to hold the suture in place. Also, when you push that cornea down, you will end up with folds. So that also sometimes worries people, but those folds usually iron out over time. And the idea is to give tectonic support, and then also you will get a visual improvement. So this is an example of a case of keratoglobus. As you can see, there is a diffuse thinning, and the benefit of this procedure is that you are not disturbing the limbal stem cells, because the limbal stem cells are important for healing, having an intact epithelium later on. So here, this is a lamellar dissection. The host cornea is being dissected, and then peripherally a rim or a pocket is being made, which is going to be used to tuck in the donor cornea, and then it is sutured. So as you can see, at that time, we were not getting the disposable trephines in large diameter. So this was the reusable steel trephine, but now we do get disposable trephines of larger diameter. And here is the peripheral rim being thinned. If you have the cornea extremely ectatic and you're not going to be able to press it down, then you can make a small paracentesis to decompress the AC, simply to allow that cornea to be tucked into position and pressed down. So this is an example. And this is another video of the similar procedure done recently. To now give you one more example of a surgery. This particular patient, so the previous was a case of keratoglobus, and this video is of a patient who had a PMD, which was advanced. And as you can see that there is it is looking like a keratoglobus, but there's a distinct, more severe thinning inferiorly. So here a large diameter trephination and the lamellar dissection. Sometimes it tends to bleed during this process, and you can use topical adrenaline soaked swab sticks to control the bleeding. Do not use cautery, and even pressure with the swab sticks soaked in adrenaline is fine, adequate for these patients. Surgery can be done under general anesthesia. If obviously if the patient is a child, it has to be done so, and for an adult, it will depend on the comfort of the surgeon. If the block has to be given, one has to be very cautious. So general anesthesia would be preferred, but it is not mandatory. Surgery can be done under local anesthesia as well. As you can see, the donor cornea is now being trephined and is now being fashioned and customized to fit in, and a 360 degree, and then it is being tucked into position. As you can see, there was some bleeding, and that interface should be washed. And sometimes the donor corneal diameter is not adequate. You know, sometimes in Indian eyes, sometimes even a healthy normal cornea may be only 11.5. So sometimes you do end up with this rim, which can be a little bit difficult. So in that case, you have to trim it down more, but make sure that at the end of the surgery, you tuck in the donor all round so that there is no discrepancy in the host graft junction. And you put a BCL on at the end of surgery. The bandage contact lens is left for a week, and then it is removed. So surgical pearls, I will mention that in case by chance you do perforate, as has happened in this situation, then you can leave that area and you can put air in the AC and continue in another direction. By then it automatically seals, or you can even put a drop of fibrin glue. And ASOCT can help, of course, but it's not mandatory that you use ASOCT during the surgery. So with that, I'd like to thank all the cornea faculty, residents working at RP Center, past, present, and future, as well as the National Eye Bank. Thank you for patient listening.
Thank you, ma'am, for such a clear-cut distinction to elaborate such confusing conditions, especially in pediatric patients, like what to look for and what all to actually search. That was a unique learning experience from your surgical videos, madam, especially tuck-in keratoplasty. I would like to ask opinion or tips from the other panelists. I would like to ask Revati, madam, for your experience, madam, in keratoglobus and PMD. We can take up audience questions from the audience. There is one question in the audience, like what is the youngest age in the keratoconus? Radhika ma'am, would you like to take up the question?
So the youngest age that I have seen is 6 years. However, I know that colleagues from our center, like Namrata, has mentioned even as young as 4 years. So you can get it in very young age as well.
Yes, ma'am, that is very early. Another question that is like, can we do crescentic dissection? It will be useful in the PMD. I think the last sketch which you showed, it was not like, it was little
Yes, so definitely you can do. See, if you have PMD in the early stages, it's a more of a surgical challenge actually, because it's so. Therefore, now in those cases, one would be better off, if possible, fit them with sterile contact lenses. But yes, if depending upon the case, you can do first initially a crescentic graft, then you can do later on further surgery if required. But that would be in the early stages. Crescentic graft can be done certainly for PMD.
Okay, madam. I would also like to ask Dr. Anita Raghavan, madam, for her opinion on the topic, madam. How to manage keratoglobus?
Anita, please unmute your mic.
Yeah, I have done advanced cases of PMD as well as keratoconus, but I haven't done a case of keratoglobus, and I haven't done a TILC so far. I have only one question, and that what is your incidence of peripheral neovascularization at the graft-host interface?
Yeah, so we don't get any, because you see what we, the donor tissue is tucked in, it's within the stroma itself. And it is, if you were to do a penetrating keratoplasty, there would be more of a problem. But with lamellar keratoplasty, we don't get any neovascularization. And the regimen of steroids is also not very heavy, just 4 times a day, topical steroids for 2 months, and then 3 times a day. So unless you have a loose suture, or in fact, the sutures tend to become loose sooner, so you have to be very vigilant. And the healing is also fast. So if the suture becomes loose, say after 2 months, you remove it. Before 2 months, it's better to replace, because that otherwise that area, the host graft junction, gets lifted, and then it affects the astigmatism. So before 2 months of the suture, so you should do a little bit more tight suturing than normal, because it is at the limbus and they are going to loosen faster.
Okay.
The tighter suturing, and below after 2 months, you can just remove the suture. Before that, you have to replace the suture.
Okay. Have you done any cases of a central PKP in these patients with limbus to limbus LKs?
Yes,
For optical purposes?
No. Luckily, these patients have done reasonable well. And I wanted to say that even if a person gets sometimes 624, 618 vision, that is satisfactory vision. The case, unfortunately, where I had to do this limbus to limbus penetrating keratoplasty was a very severe eye drops, where there was like a big rip in the cornea, and even when we were trying to do the air injection, the air repeatedly was going within the stroma. So it was extremely difficult. It was for that patient. Then I had to convert. I had actually taken up for air injection. That was becoming impossible. So that patient, I did a limbus to limbus penetrating keratoplasty. That patient was given systemic steroids as well as topical tacrolimus. But he did come back with a graft rejection 3 months later. But that graft rejection was successfully treated with intravenous steroid. So it's not that it is impossible to do. It's something better to avoid. Somehow the cases where we done lamellar surgeries, we not had the need to do a central penetrating keratoplasty because they have reasonable vision.
Okay. Thank you.
Madam, I have a question. Whether managing cataract and PMD and the IOL power calculations, how do you decide, madam, while doing keratoplasty and cataract management together?
Quite right. Now, the problem would be very good question. Problem comes if the patient is young and has a cataract, because then that PMD may still be in the progressive stage. So therefore, if it's an early cataract, it is better that you do surgery for the PMD, or make sure it's stable, and then you take the existing keratometry and go for the cataract surgery. Problem comes if it's a total white cataract. You can get sometimes a total white cataract where the patient has no vision at all and waiting is not an option. Then what one would do is use the existing keratometry and explain to the patient that one will have to be take care of the residual problems later on with glasses or contact lenses. And one more thing, if you're doing cataract surgery in any of these patients, you have to make a more scleral incision, because particularly in keratoglobus, you can have a triradiate tear with your wound entry. Plus, also make sure that you use very low parameters, because otherwise there can be sudden collapse and sudden changes in the corneal biomechanics. So you have to be very careful when doing cataract surgery.
Actually, there is always a fear, like doing a case of touching a case of a keratoglobus, because the peripheral thinning is also very much thinned out as of the center and the mid periphery. So I was like astonished to see your video with by you're doing tucking everything. It is it's very difficult procedure. And I feel like scleral thinning is also would be there associated in these cases, which is a very difficult situation to handle. And Revati ma'am has joined. Ma'am, give your inputs, ma'am, in managing these cases of advanced ectasias in your practice.
Thank you, Radhika, for your very, informative videos also, very nice. And I have done few cases of this tucking in. Initially, of course, you have to find out your own way of doing it. Of course, after seeing your videos, now I have more clues. Like initially, just after listening to Dr. Vajpayee's talk and Namrata's talk, I just started. And there will be, as Anita pointed out, scleral area also we have to be careful, and we won't know the periphery flange, how to make it on the donor cornea. All these things will be there. But they are, to my experience, they are quite gratifying also. In some of the patients, they are really giving good thing. Even with the PMD, Dr. Reddy is doing this tucking in stromal enhancement in PMD. Same way I try with the suturing. In one patient, at least I tried, and at least the cylinder has come down from 12 or something to 5. So that now both eyes are matching. At least that much I was able to bring down. And amazingly, Dr. MSR used to do just a wedge resection and compression in PMD. Simply like without any addition, add-on tissue, just he'll compress. And that also used to give great results. Recently, Srinivas Kera also showing the same thing. And another thing we have to keep in mind about brittle cornea. When especially planning for cataract surgery, the brittle cornea can be a nightmare. Even I feel I'm more scared about brittle cornea than even a keratoconus or PMD in this thing. Any particular advice, Dr. Radhika, in these cases?
Brittle cornea?
Yeah, brittle cornea, a cataract if it be go, or if they come with a trauma.
Yes, so definitely these are very challenging cases, and if you are doing cataract surgery in them, then you should do it with a scleral tunnel, and be prepared with sutures and even sometimes glue, and also counsel the patient beforehand. If they come with trauma, then you can have very irregular triradiate or multiple radiating incisions, and you may have to use a purse string suture. You may have to use your own sort of innovative style to repair that wound. And putting the bandage contact lens is something I will say as a tip on the table. So that should also be available in the OT, and then you can easily remove it after 1 week. It makes the patient more comfortable.
Thank you.
Thank you, madam. We will try to take up a few questions from the audience chat box. Is there any role of combined C3R and laser vision correction in the treatment of PMD? Like, can we go? I think it means, can we go for any refractive correction like ICL or something in cases of PMD? Madam, what would you like to say?
So definitely C3R can be done for PMD, but here the challenge is that you have to, it's not standardized for PMD, so it has to be eccentric. You have to mechanically protect the limbal stem cells. So it's not a very ideal treatment, but it can be, it has been done and it can be done. The other thing is that laser vision correction. So once it is stable, if the patient is very much concerned about having a refractive procedure done, then in early cases, provided it is stable and you watched it for 1 year, you could consider for ICL. But I personally am a very conservative person, And I would like to the patient to understand that it's a very difficult situation. You should be willing to accept that it is not a totally safe procedure. And you can try contact lenses or even often spectacles. Many people with PMD, 618, 612 vision, they're able to do all their routine activities quite well. It's just in the mind of the person that they feel that the eye is abnormal. Often the other eye will be quite good. So you have to tell them that with both eyes open, you're functioning perfectly fine. So, it's just a question of the patient thinking that my eye is very diseased. And if the question was related to doing something like LASIK extra, etc., I think these are disease corneas, and any corneal-based refractive procedure, it's not seeming warranted. But definitely cross-linking something that can be done if it's a progressive and in the early stages.
Thank you, madam. Another question we have in the question box is that how do we address the stromal scarring after the eye drops? Is lamellar keratoplasty useful, or what are the options what we have?
Correct. So sometimes with acute eye drops, when it heals, and definitely if you inject gas in the anterior chamber, it promotes faster healing. So unless it's a patient is a GA-RIS, a Down syndrome, or patient has come late, I would say that I would recommend going for gas injection for acute eye drops. And once that has recovered, you assess. Sometimes the healing of the eye drops, in fact, improves the keratometric values, and sometimes the vision can also improve, and they can go for glasses or contact lenses. But otherwise, you can go for a DALC procedure. There again, you can trial a big bubble DALC. Otherwise, you can go for manual DALC, the maximum depth LK. I would always encourage, because you see, even if there is a full thickness injury because of the eye drops, often it is very localized, and the rest of the endothelium is very healthy. Cannot be more. The donor tissue cannot be more healthy than the patient's own endothelium. So at all situations, I would encourage that you try for a DALC, even if you're not going to get perfect 6/6 vision, but it is better in the long run compared to a PK. Whether you do manual or big bubble, that will depend upon the case.
Thank you, madam. That was such a fruitful discussion for young cornea surgeons like us. I think we'll go on to the next. Yes,
the child, if there is a scar, as Radhika pointed out, I used to try hydrodissection than big bubble straight away, because that can suddenly expand and give way. So hydrodissection, you can do it. It's a hybrid of manual and this thing that will give good results.
Okay, madam. So, since this is such a vast topic, I would also like to ask opinion from the panelists. Yes, madam. Anita, madam.
For a lot of patients with Down syndrome combined with advanced keratoconus who present with eye drops, a combination of compression sutures with the gas injection in the anterior chamber really helps, because the DM comes together very quickly. And a lot of these patients, what happens is subsequently when you look at them, you find that there's enough flattening to get good vision. Because there's those patients for whom we cannot, like for the issue with patients with Down syndrome is that suture removal is an issue. The patients very often don't communicate with their family, and graft rejection is always a possibility because there's no understanding from the side of the patient. For such patients, I have found that, like after you do the compression sutures combined with the gas injection, you find that the vision improves considerably. You can see a lot of difference in the way the patient comes into your cubicle. They'll be walking independently. And so such patients, I tell them, don't do anything so long as the patient is able to move about. This is like, very bad cases of Downs. I'm not talking about the borderline Down who can sit and show you your face on this little lamp. But for such patients, I found that this is a very good option. The scar keeps the cornea fine. There's less chances of having, a rupture again, all that. So this is one option that I choose very often.
Okay, madam. Since this is such a vast topic, I would like to ask other panelists also for their experience, their opinions. Dr. Mangala, madam, Dr. Seema, madam.
Actually, as madam was telling, I don't have any personal experience in doing tuck-in DALC and all. I'm doing normal DALC, but I've seen madam doing tuck-in DALCs, and I think in future we will also try to take up all these tips, and we'll start doing these cases. We have enough cases with advanced PMD and Globus. So I think this all these things will help us, and we'll start soon. Thank you, ma'am.
Thank you, madam. I think we'll
Aditya,
move on to our...
just
Yes,
one
madam.
thing. Can we ask Dr. Reddy, in case of Downs and children like this, no, where we are scared about their how they will manage with the graft, the stromal enhancement procedure may be a safer option. Dr. Reddy, do you think like that?
Early cases, madam, but the late cases, usually Downs early cases, they don't come, they come with hydrops and very advanced keratoconus. So generally we are going for a tuck-in doll in those cases. So we had an injury, one of the cases tuck in doll, but luckily it didn't rupture, it just came out. So we are able to restructure the lamellar graft and it is doing well. So advanced cases, early cases, usually they don't come. Early cases we manage by cross-linking. In Downs, they do well. But lamellar keratoplasty is definitely a good option, but provided the Downs child is seen early and we screen them. Advanced cases, not possible. No good.
Thank you everyone for their inputs. Let us move on to our next topic, unveiling clinical and topographical features of ectasia by Dr. Anita Raghavan, madam. Consultant, Cornea Refractive Services, Aravind Eye Hospital, Coimbatore is here with us. I apologize for that brief interruption. Sorry, madam. We will try to play the video now.
And the Tirunelveli team for inviting me to be a part of this webinar. My topic is unveiling the clinical and topographic features of ectasia. All of us are familiar with the clinical signs of established keratoconus, namely paracentral corneal thinning, corneal protrusion, warts striae, and flacious wing. In the early stages of keratoconus, all that you can see is the scissoring reflex on retinoscopy and an inability to get a best corrected visual acuity of 6s. History is also important. There'll be a frequent change of glasses. One very important red flag is an young male, more than 18 or 19 years old, without a history of using glasses who suddenly is present with defective vision. Such patients require a very good keratoconus workup because there could be an underlying PMD. A family history of keratoconus and of BKC is also important. Rabinowitz classification still holds good. This is based on axial topography as well as clinical signs. Basically, you have three components. You have clinical disease, you have early keratoconus, and you have form frustrate keratoconus. In the first one, you have the obvious clinical signs as well as the typical topographic pattern, whereas in early keratoconus, all that you have is scissoring plus the typical topography. In form frustrate keratoconus, only the topographic pattern is present. So therefore, the current focus of all topography technologies is the earliest possible detection of subclinical keratoconus with the greatest possible specificity and sensitivity. The methods may vary. To describe the surface the geography of a surface, you call it topography. You can describe it in any way you want, the elevations, the depressions, the terrain, etc. But when you want to compare it with something else, you need two things: a standard that is considered normal or the baseline, and you also require a scale. For the Earth, the scale is the sea level. When you take Mount Everest, the height is 8,848 meters. It's a huge challenge for anyone who wants to climb it. But when you look at it in the context of the diameter of the Earth, which is 12,000 kilometers plus, it's a very small thing. It's just a tiny elevation on an apparently normal surface of the globe. So this is why local elevations are important, and this is why you need to highlight local elevations to study things better. For the cornea, therefore, you need to establish a meaningful reference surface. Different topography machines do this in different ways based upon the acquisition of data and also on the evaluation of data. The first machines that came in for topography were Placido-based devices. They basically studied the anterior curvature of the cornea. When the OBSCAN came in, it introduced slit scanning. It also happened to be the first tomography devices. Subsequently, with the onset of Shane-plug-based devices, came better elevation and Pachy-based topography machines like the Pentacam, the Sirius, and the Galilei. Finally, we have the OCT machines, which are very good for pachymetry and also have the added benefit of doing epithelial mapping for us.
We will first discuss the OBSCAN as it is widely used. In Placido disc-based topography, a series of illuminated mirrors are projected onto the cornea, and it calculates the corneal curvature from the quantum of distortion and the size of the mirrors. You have a very excellent representation of the anterior corneal curvature. When in the OBSCAN, to the Placido disc-based topography, slit scanning is also added, so you therefore get corneal thickness, curvature, and elevation data simultaneously. Now, intrinsic to all topographers are the curvature and the elevation map. Fundamentally, you get a lot of data from these two maps. And however, the method of calculating the data can vary from machine to machine. But all this is common to all topographers. Warmer colors represent steeper keratometric values and or increased dioptric values, whereas the cooler colors represent flatter cave with lower dioptric values. The greens and the yellows represent the normal cornea. When you use the color scale for surface curvature, red indicates that the curve is sharp. It indicates this is a fast bend and a short radius of curvature. Whereas when you take the blue color, it indicates that the surface is flat, there is a slow bend and a long radius of curvature. Color codes are not absolute. The choice of incremental steps will vary. Take a look at this. This is the Mariana Trench, which is 36,800 feet deep, the deepest point of the ocean. To represent this on a scale, you need to do it in meters, but it is so deep that the incremental steps are every 1,000 meters. Look at the scale. This is 1,000 meters above sea level, whereas this is 11,000 meters below sea level. So the same colors are used for corneal topography, but what you have to keep in mind is that the scale differs. It is in microns or in diopters. Smaller steps increase. The smaller steps increase the sensitivity to pick up early keratoconus. Higher false positives are also possible. Larger steps, early changes are not picked up, but higher false negatives are possible. Therefore, topography should not be evaluated only based on the colors. You have to look at the scale. When you come to elevation, the measurement of elevation is relative, subject to a best fit sphere. The best fit sphere is a mathematical model that is the closest fit to the corneal surface. For each cornea, the best fit sphere is different. So therefore, it's difficult to compare elevation maps. Now, when you take warm colors will represent a high surface anterior to the reference surface, whereas the blue colors will represent low or posterior to the reference surface. This is the representation of a normal cornea, which is prolate with subject to the best fit sphere. So when you look at it in comparison with the best fit sphere, you have a central elevation, and this is called a central hill. Then the cornea dips below the reference surface and then it again gets slightly elevated towards the periphery. When you take an astigmatic cornea, what will actually happen is that the steep or the sharp profile will fall below the reference surface, whereas the flat profile will rise above the reference surface. Such an astigmatic cornea is called as a central saddle, and it's a pattern that you see very often. Now, when you come to the curvature maps can be represented in different ways, the most common one being the axial. This is also the map that gives you the maximum amount of information, and it evaluates the overall shape of the cornea. This measures curvature in the axial direction related to the center. Most importantly, you get all your patterns are identified by this map. But one of the things about the axial map is that smaller or local irregularities can be missed and the peripheral curvature measurements are not very accurate. To obviate this, you can do the same thing. You can use a meridional or a tangential scale. This measures curvature in a meridional direction relative to the other point in the particular ring. This is more sensitive in detecting local curvature change, more accurate in the corneal periphery. However, this is subject to more variation. You also have curvature maps can also be represented by an absolute scale or a relative scale. The absolute scale is not available on the OBSCAN, but fundamentally this is a fixed color coding system which is intrinsic to each system. You cannot change the dioptric range. So what happens is whatever you put up, it will always have the same scales and the same dioptric range. So therefore, this is good for direct comparison of different maps. And this is done in large incremental steps of around 0.5 to minus 1.5 diopters to 1.5 diopters. So therefore, you can miss subtle changes of curvature. You can do the scales as a relative scale. That is what you saw previously. Here, the color scales will be variable map to map. What happens is that the machine identifies the minimum and the maximum dioptric values of the cornea that you're studying. It then assigns a range of colors, and the dioptric range also is smaller for each step. So this basically highlights more topographic details, but since the scale is set for each cornea, once again, map to map comparison can be difficult. Now, with this background, let us take a look at some normal maps on how to use the OBSCAN. Basically, when you take the OBSCAN, you have 4 different maps. You have an anterior elevation of the anterior float, a posterior float, the axial curvature map, and a pachymetry data. First, let's go to the curvature map. It gives you a lot of information. You can identify the pattern. You get to know the power of the cornea. You can see whether the cornea is symmetrical, study the axis, and also see whether the cornea is orthogonal. Take a look at this map. On the main thing that you see here, or the first thing that you see here, is the pattern followed by the power. Now, when it is a fairly symmetrical cornea, and you can see that the central cornea is the power is 45 diopters. A power in diopters greater than 45 is suspect on the OBSCAN. However, some topographers use this as a quantitative index whereby they study points around the second or the third or the fourth ring of the Placido topography and then give you an overall value. In such topographers, a central K reading greater than 47.2 diopters is significant. However, in the OBSCAN, a central keratometry difference greater than 1 diopter is considered significant of keratoconus. Topographic patterns can also be identified. The normal cornea is supposed to exhibit a phenomenon called enantiomorphism, whereby both eyes exhibit mirror image symmetry. Now, the patterns that you normally encounter are round, oval, superior or inferior steepening, and irregular. You also have the various categories of bow tie. This is a symmetric bow tie. This is a symmetric bow tie with a skewed axis. This is a bow tie with superior with inferior steepening, and then this is an asymmetric bow tie with superior steepening. This one is an asymmetric bow tie with skewing. This particular pattern is supposed to be very pathognomonic of keratoconus. In fact, 80% of the healthy eyes in unilateral keratoconus will show this particular pattern, and overall there is a 50% progression risk. So how do you calculate the skewed radial axis? Take the horizontal, take your 2 steep meridians and bisect the axis and just measure the angle. You will get your SRAX. The curvature maps also help you to identify astigmatic patterns. Here you have with the rule, you have against the rule, and then you have oblique. You can also study patterns of ectasia. This is keratoconus. You have inferior steepening, and you can see the advanced keratoconus here. In this map, you can see against the rule astigmatism, the characteristic clap claw pattern of PMD with a corresponding flattening in the opposite axis. On the elevation maps, what you normally see will be the first thing that you look at is the anterior elevation or the float. On the OBSCAN, a value greater than 15 millimeters is suspect. The posterior elevation, a value less than 40 is normal, 40 to 50 is suspect, and greater than 50 is keratoconus. A value on the posterior best fit sphere greater than 55 diopters is also suggestive of keratoconus. A value between 53 to 55 is suspect. However, a posterior best fit sphere greater than 55 can be seen in small corneas where the wide to wide diameter is less than 11 millimeters, also in very steep corneas, and also Asian eyes are more prone to prolateness. So this is the pachymetry map. Basically, you have a range between 500 to 600 is considered normal, less than 480 microns is suspect. Displacement of the thinnest point on the pachymetry map is very important. Usually the displacement is in an infratemporal direction. You also can take the ratio between the thinnest point and a 0.7 millimeters on the 7 millimeters ring in the periphery. If that value is more than 100, it is considered significant of keratoconus. So now let's take a look at some abnormal maps. This is a fairly normal looking map, except for the anterior elevation, which is 24. And then you also have a posterior, and you also find that you have a steepening of the axis. But there is no skewing and there's no inferior superior dioptric asymmetry. More importantly, the posterior elevation is normal. And this is warpage due to contact lenses and will resolve once the lenses are discontinued. Now, the anterior elevation value here is high, so too is the posterior elevation. And you also find that the thinnest point is, however, normal at 503. However, the anterior, the posterior, and the thinnest point coincide, a point that is called, this is called as a 3-point touch, and this is considered significant of keratoconus. It is important to note that in this particular patient, the SIMS K is within normal limits, both at the 3 and the 5 millimeter zone, but you do have a significant inferior superior asymmetry. This is early keratoconus. You have anterior and posterior elevation with an asymmetric bow tie, inferior superior dioptric asymmetry, and you also have keratoconus. This is, once again, all the 4 maps are abnormal. You have anterior elevation, posterior elevation, the inferior superior dioptric asymmetry, you have skewing, thinning of the cornea, and also all the numerical indices are abnormal. This is another patient with advanced keratoconus. You see the same features as you saw in the previous map, except that the values are all much higher. Take a look at this map. All the numerical indices are normal, except for the posterior elevation, which is high. The central Ks are normal, the overall Ks are normal, but both the anterior elevation and the posterior elevation are decentered. This is early PMD. This is frank pellucid marginal degeneration. You have decentration of the anterior and the posterior elevation. You have flattening of the vertical axis, and you have steepening of and you have a crab claw pattern. There is something also called a difference map that is available on the OBSCAN. Basically, the difference map compares 2 maps in different time frames. It helps you to evaluate progression. Only the difference between the 2 maps are represented. Green demonstrates no change. And this map shows no progression in a patient over 3 years. In 3 years. Basically, you need good alignment for meaningful comparisons. This is once again a difference map in a patient with keratoconus. The maps are taken 4 months apart. Here you can see significant steepening in the center, indicating progression. Now, it's very important to take a look at all the 4 maps. Now take a look at the axial map. This is where our eyes go to usually. But if you take a look at this map, everything is normal except that the central K is 46. But however, when you take a look at the anterior elevation is abnormal, so too is posterior elevation, and the Pachy is very thin. This is why you need to study the OBSCAN with all the 4 maps in play. KC progression is not bilaterally symmetrical. You take a look at this, all this is really abnormal, whereas in the right eye, you just have a borderline posterior elevation and a borderline thin cornea in this map. Good quality scans are mandatory. You need to get accurate measurements, you need a stable tear film, you need a good patient fixation, adequate exposure to the cornea, and the lids must not obscure the superior and the inferior quadrants. False positives are possible when you compress the globe while attempting to retract the lids, when you misalign the eye with superior or inferior rotation, when the Mayas are not properly digitized, or you have dry spots. Both of them can simulate inferior steepening. Now, corneal topography basically gives you a lot of data, but however, the sensitivity is 87% and the specificity is 92%. And you also have a false positive rate of 0.5% and a false negative rate of 2.5%. Higher specificity and sensitivity is possible by using mathematical indices. Let's take a look at them. You have global indices, for example, like the Q value, where the entire topographic surface data is evaluated. You also have local data. For example, the inferior superior index is a local data because it uses only partial amount of information. You also have integrated or composite data like the KISA percentage, where multiple indices are clubbed together. So the composite indices offer higher specificity and sensitivity, but however, they're specific for different topographers. When you take the inferior superior value, this is the power difference between 5 inferior points and 5 superior points, 3 millimeters from the center at 30-degree intervals. On the OBSCAN, a value less than 1.4 is considered normal. 1.4 to 1.9 is considered suspect, and a value greater than 1.9 is considered abnormal. The Rabinowitz criteria is something that is seen in a lot of topographers. Basically, it integrates the central keratometric value, the inferior superior dioptric asymmetry, relative skewing, and the keratometric astigmatism to generate an index. If you have a number greater than 100%, it's highly suggestive of keratoconus. If it is greater than 60, it is subclinical, and if it is less than 60, it is normal. There are other indices also which evaluate the surface. For example, you have the surface asymmetry index. This is important because you compare two principal oblique meridians for symmetry. You take 2 points on a ring 180 degrees apart and study the value. And this, if a value greater than 1 is considered abnormal, one of the important things about this particular index is that it can quantify the progression of keratoconus. You also have a surface irregularity index where points in the central 4.5 millimeters are compared with their surrounding points. The simulated keratometry, you know, all of us are very familiar with it. It is equivalent to keratometry. You take the steepest axis and an axis 90 degrees to it, and you take the average power at the 3 millimeter zone for comparison. Now let us move on to the pentacam. The pentacam uses Schoenflug generated images, and then it integrates anterior and posterior elevation and the Paki data to give you a complete overview of the corneal shape. Now, when you take a look at the map on the left, it is very similar to your OBSCAN. It offers a 4-map refractive map. Then the data that is available to you from these maps is then generated in the forms of numerous indices. One of the most common and the most popularly used one being the Bellin-Ambrosia Enhanced Ectasia Display. This is a multivariate index with 3 components. On the left, you have the KC staging map as well as the Bellin ABCD progression display. When you take the Bellin-Ambrosia Enhanced Ectasia, on the left you have the elevation data and on the right you have the pachymetry data. Let's take a closer look at these. Now, when you take the elevation data, up here you have the anterior elevation and the posterior elevation assessed with a standard Besford sphere. This is the same anterior and the posterior elevation assessed with an enhanced reference surface, and this is the difference between the two. The difference here is that the enhanced Besford surface is basically done from the central 8 millimeter zone after excluding all the data from a 3.5 to 4 millimeter zone centered on the thinnest pachymetry. The amount of the exclusion zone is determined by the computer and also, or rather by the software, and varies based upon the amount of astigmatism. The difference in elevation values is color coded. Less than 12 microns is normal, 12 to 16 is abnormal or suspect, and greater than 16 is abnormal or suggestive of keratoconus. Now, the pachymetry values are basically derived by assessing 22 concentric rings, 0.4 millimeter increase in diameter centered on the thinnest point. From this, you generate 2 important data. One is the corneal thickness spatial profile, and the other one is the percentage thickness index. The first one is a progressive thickening of the cornea from the thinnest point to the periphery along each of these concentric rings. The percentage thickness index indicates the percentage of increase in thickness from the thinnest point to the periphery. Now, this central line here denotes the normal base, and this is a 95% confidence interval. The cornea that you're studying is represented by this red line. You also have the pachymetry progression index. This is the percentage of progression of thickness from the thinnest point to the periphery and is considered to be a very sensitive index. It evaluates changes in thickness 360 degrees around the cornea. And the progression value at each meridian from the thinnest point is defined as PI. So here you have a minimum value, you have a maximum value, and then finally you have an average. A rapid rate of pachymetry progression distinguishes an ectatic cornea from the normal. You also have the Bellin-Ambrosia Enhanced Display 2, which basically has 5 parameters. One is the change in the anterior elevation from the standard to the enhanced reference surface. The same thing for the posterior elevation. You have a pachymetry progression, corneal thickness at the thinnest point, and then also the thinnest point displacement. All these 5 put together gives you the big D, where you have big D. And finally, this is all these values are represented as normal, 1 standard deviation and 2 standard deviations from the mean. You have some more indices, and this is especially seen in the keratoconus staging map. For example, you take the index of surface variance and the index of vertical asymmetry. These two indices are very important because they're highly sensitive and differentiates keratoconus from normal eyes. And the IVA is also highly specific for pre-keratoconic corneas. The ISP is important because it can monitor progression. The IVA is considered second to the BAD-D in terms of accuracy in predicting keratoconus. You also have 4 additional parameters but subsequently added to the pentacam. This includes the Pmax, Kmax, and you have the anterior and the posterior elevation at the thinnest point. You have the ART max, and you also have additional individual parameters like the steep and the flat stimulated keratometry and also the Q value. The Bellin ABCD keratoconus staging system utilizes 4 parameters. This is good for studying progression. So basically, parameter A is the anterior radius of curvature in the 3 millimeter zone centered on the thinnest location. Similarly, you have the posterior radius of curvature, that is B. Then you have parameter C, which is the thinnest pachymetry in microns. And finally, you have parameter D, which is distance best corrected visual acuity. The critical difference in this particular map or display is that the posterior curvature and the thickness measurements are based on the thinnest point and not on the apical. This is important because sometimes when you take the apical thickness to the cornea and the thinnest point in some very thin corneas, the difference might be as much as 100 microns. Now take a look at this map. This is the keratoconus progression map basically. Here is the Bellin enhanced ectasia scale. This is in 2019, this is 2022. And then you have the same thing where you have as a KC staging. Now this can then be displayed as a progression display. So you have the values here in 2019, and this is again, I think in 2021 and then in 2022. You compare all this and then you have a classification. So A1, B2, C, 0 and D. So over 3 years, there is no progression in the keratoconus. You also simultaneously on this map, you get all the other values too. You get the ISV, you get the IVA. So take a look here. This is 44, 45, 44, 47, 48, and 47, indicating no progression. A few words about the use of the OCT in certain specific circumstances. The OCT gives you very specific pachymetry and probably the best pachymetric data that you have. Now, this is an axial map, and here you find that it looks fairly normal. But when you take a look at the posterior elevation, there is a significant abnormality. So when you take a look at the pachymetry, you find that corresponding to this point, you have a lot of thinning. And when you take a look at only the epithelial map, you find that the epithelium in this area is very thin. And this is why it appears that the axial map is normal. So the OCT will be useful to you in such circumstances. The global consensus on keratoconus as an ectatic diseases in 2015 concluded that there is a need for better progression determinants, and that to diagnose keratoconus or progression, you need a consistent change in at least 2 parameters. The parameters that they have fixed upon is thinning of the cornea, steepening of the anterior corneal curvature, steepening of the posterior corneal curvature, and an increase in the rate at which the corneal thickness is changing from the periphery of the cornea to the thinnest point. However, what defines progression, the numerical values for each has not been assigned. However, in the OBSCAN, what we use is an increase in the central K more than 1 diopter. This basically comes at the end of my presentation. And I would like to share with you a few maps which addresses some of the concerns that I have about the various display maps. One thing to remember is that the pentacam is fundamentally has a lot of bells and whistles and everything is given to you. I mean, you don't do any evaluation. My question is that, do we always go blindly with what we see on the pentacam? Now, let's take a look at these 2 patients. This is a patient where, you can see that all the 4 refractive maps show frank keratoconus. You can see you can see the gross inferior superior dioptric asymmetry. But when you take a look at this map, once again, this is abnormal. All this is abnormal. But the CTSP and the PTI are fairly normal. My question is, why is this? Take a look at the OBSCAN values. This shows the keratoconus, a well-defined keratoconus. Okay. Now, one more patient. Once again, if you take a look at this, you find that you have skewing, you have superior inferior dioptric asymmetry, everything is there. You go to the Bellin distance, the anterior elevation is abnormal, but the posterior is normal here. Why is that? And once again, you find that the CTSP and the PTI are within the normal range. Take a look at it. This is the corresponding OBSCAN map for the same patient. So it will be nice if we can have a discussion on these two cases. Thank you.
Thank you, madam. Corneal topography is always a colored maze or chakra view for beginners like us. It is important to know the patterns, SRX calculations, and all the parameters for beginners. Thank you, madam. You made it sound very easy. So it is very difficult to understand. I would like to ask opinion, Dr. J.K. Reddy sir or Dr. Rohit Shetty sir about the pentacams, about the last discussions which madam is sharing.
Is basically it's not one parameter. You have to work on all. That's what Dr. Bellin says. You just don't look at one parameter. Look at the R value, and that's how he has evolved in that particular. If you are using pentacam, you cannot just pinpoint anterior elevation, posterior elevation, percentage of corneal thickness. You have to look at all parameters and comes to a conclusion. One parameter you cannot take it. So looking at these maps, there's a clear case keratoconus according to the pentacam. It is labeled as a keratoconus. That's all. According to this system, it all depends upon how they evolve the system and how they design it.
One of the reasons why I put up these maps was because, you see, I've seen a lot of people just going by the color coding of the pentacam. It's like, okay, it's like a traffic signal. Green, go, yellow, have a doubt, and then red, don't touch it. But I feel that there has to be a little bit more of evaluation of the pentacam. So very often these days, I find that though the OBSCAN is supposed to have less accurate PACI and elevation data, in some of the cases like this, I find it's quite the opposite. So I'm really puzzled as to why we have, like the difference map on the Bellin ambrosia, you find a green here. It should not be. That's what my thing is, which means that probably the enhanced reference surface is not doing what it's supposed to do.
Oh, no, not like that. It is the data. It is the exact data. According to the pentacam, you have to repeat pentacam. Even if you repeat, you get it. It is the data of the patient. So how we interpret depends upon the many values. That's why they are having so many values. If only one value is, see, OrbScan, solely OrbScan is sold as posterior elevation. Posterior elevation, 1 point only OrbScan was sold. It's not like that. Pentacam is not posterior elevation alone. It is a combination of multiple factors. So that gives the ultimate value of whether the patient is a suspect or a not fit for refractive surgery. It is a basically screening tool, pentacam, to screen off more, land in a more safe zone. It will be false positives will be more in pentacam, but still it is okay. He doesn't want to have false negatives.
Does anybody else have any comments on these two scans? I would like to hear something more. And basically, my question is very simple. I'm not saying that I'm going to do refractive surgery in any of these cases. I'm simply asking, why is it that I'm not seeing something more on some of the parameters that I've displayed? That's my only question.
You want to post elevation in this map. You want to post elevation, but that is not there. Okay. You want to see a post elevation associated with anterior elevation in this map. That's what your mind is telling. I want to see it. It is there, you are thinking. But according to the data collected, there is no posterior elevation.
Okay.
I have a little I'm also like, sometimes you do get these cases which are puzzling, where you find that things are not correlating. So there are 2-3 things that one can do. One is that when you find this discrepancy between the anterior and posterior, then it could be a surface problem also. So you can give lubricants and recheck the patient after a month or so, or maybe 3 months. The other point is that, again, take a careful history of contact lens wear, because sometimes patients, either the person doing doesn't ask, and sometimes patients just take it like a normal thing. So they may even have used a cosmetic contact lens, or even have used a contact lens. Sometimes they may have used it even for half an hour or something. So no harm in checking, rechecking. So basically what this is showing is it's not fitting in. And when it's not fitting in, don't be categorical whether it's normal or abnormal. At that time, we are in a borderline stage, and try to see in which direction we are going. Is it, generally what I find is, when I find the anterior different, and the, as you correctly showed, the facial thickness profile and all that are healthy, then I would give lubricants. And another machine which can help is the Corvus. Corvus biomechanical index can be also tested, but that again adds another layer of complexity. Many times we find that the Bellin-Ambrosio displays perfectly fine, but the Corvus is showing some abnormality. So the more and more equipment you get, sometimes it can be confusing. Sometimes everything fits in and it's very helpful. So in those cases, then you have to, it just gives you an additional parameter of safety and a point to follow on, follow up and decide. So I would say that such abnormal cases or such borderline cases, definitely don't go for refractive surgery straight away, but whether it is keratoconus or not, what is the cause, etc. Now that's a very interesting observation of yours about the OB scan, because most of us have now rejected the OB scan, and most of for us the OB scan has become defunct and we no longer look at it at all. So the point that you have an OB scan, and this particular patient, you have done the OB scan and found that, so that is just showing that OB scan was more equipment which was taking into the surface into account, whereas the pentacam is also taking the thickness more. I mean, the parameters and the values are there. So I can understand that the OB scan may have helped you to look at it, but you have to now sort of remove the OB scan mode and just work on the pentacam, because it's a tomography, and because there are many ways that it may be the other way around also. So it is helpful if you have it. Then you can also look at maybe have a series of such cases and see what could be the parameter, and maybe follow them up for some time also. But I personally feel that if you give this patient lubricants and maybe just again ask about eye rubbing. Sometimes they have a habit of splashing water also very vigorously on the eye. It happens sometimes. And sometimes that itself may be a cause for that distortion. So these things you can look at and then reassess the patient after 2-3 months.
Yes, ma'am. Actually, we have the case selection for LASIK has been drastically reduced after the pentacam. Like when we were in the OB scan era and now in the pentacam, case selections have come down. And whether like as madam was pointing out, the bad map is showing yellow on the elevation, anterior elevation alone, and other maps are absolutely fine. But now in beginning times when the pentacam was new to us, we were like rejecting those patients. Then they would have gone to another center, they would have done the surgery anywhere else. So nowadays we are not.
When rejecting the patient, firstly, you don't tell the patient that you're rejecting. You say that you counsel them, make them understand the reason, so that they don't, just think unnecessary rejection. And you tell them that this is what we can do. And we have, say, over the last 1 year, this has happened more to us, exactly what you're saying, that, we were thinking that what were we doing earlier? And now we're finding many patients who we would have medically operated on. The moment we take the Corvus into account, now that you have a value which is abnormal, sometimes with the biomechanical index abnormal, then once you have it, even though the Bellin-Ambrosio is abnormal, you don't want to go for the surgery. But so the last 1 year, we're following up such patients, and I would say very rough figure, a very preliminary at the moment, to say out of 15 such patients, 5 have improved with lubricants and vitamin C, and then have gone ahead to undergo the surgery, and they're now on follow-up post-operatively. So the thing is that the more the more we go for safety, obviously this is going to happen, and it's always good to make the patient understand, because ultimately it is a patient who should not be ending up with a problem. It's not that you're rejecting for no rhyme or reason. So patient has to understand that there is a risk involved. Then if the patient goes ahead and does it irrespective, that's different. But you have to explain your reasoning.
Anita, you can also see the previously such cases whom you have operated. If you have good follow-up, whether any of them have developed ectasia or any other problem, then that also will give retrospectively an idea instead of just sticking on to one particular point or something. This also will give you clue. And also you can think about such cases doing only surface procedures instead of making a flap to be on the safer side. And as Radhika pointed out, always we used to tell them the risk. Unless if they are ready to accept that risk only, you touch them. Otherwise, better tell them clearly, this is the reason why we are asking you to wait.
Madam, if I could give a few points here, ma'am. This is Dr. Seema here. Regarding, am I audible, ma'am?
Yes, you're audible.
Madam, you are audible.
It's not very clear.
Dr. Anita Madam's specific question regarding why the op scan is showing and the pentacam is not showing, the Bell and Ambrosio enhanced display in the posterior float is not picking up. So basically, the thing is like say for example in the modeling industry, there will be a supermodel. Next, you will have some other supermodel coming up, and this one will be outdated. Something like that with technology. We are having every time we are having a new machine coming up, which is giving us more information rather than the previous machine. The OpScan has basically a topographer, the surface placido based, as well as a slit scanning technique, right? So the OpScan only takes 20 slits on one side, 20 slits on the other side, and with the 40 slits, it kind of gives you the calculated data about the posterior float. It actually does not look at the posterior float directly. It is only extrapolating the data that it has taken on the 40 slits, and it's kind of assuming that the rest of the fill in the blanks is what it does. While the other machines like the Pentacam or now the ASOCTs, the MS39, these machines are looking at the actual floats. Now, if the band display is not showing us the pop on the posterior float, it is actually telling us and that's what we believe as of now until some other technology comes in and takes over. But so we believe that the band display is actually giving, it is subtracting the 3 mm zone around the area of maximum elevation, showing us the difference. So that I would consider as the true value. But like you say, we have to look at the other values also, because in the same band display, we were also seeing that the cornea is much thinner. The front elevation was showing a pop. That may not be because of ectasia per se, that may be because of the epithelium. So in case you have an epithelium mapping and you're able to subtract the epithelium map and then look at the stroma per se, that would be again helpful. But if the thickness is again showing the DP value on the Pentacam, if the pachymetric progression also is affected in these cases, then I would probably still hold my reins back and not proceed. We cannot just say that because the band is not showing a pop on the posterior float, we can go ahead. There are multiple other parameters that the Pentacam is showing as red or yellow in this. It's not about the colors, it's just about the data the Pentacam has analyzed. And probably that is why the OpScan is showing and the Pentacam is not showing in this case. It's because probably the OpScan is extrapolating data while Pentacam is actually showing us the true data. That would be my take on it. I would like Dr. Rohit Shetty or some other speakers to probably elaborate on this.
Oh, I apologize for this. Because of the time restrictions, can we move on to our next topic?
All right,
Thank you for all the informative inputs from all the speakers and panelists. Before we go on, I would like to put forth that question was asked in the chat box and answered by J.K. Reddy sir. Like which topography machine should we take as an initial device, or like to start with? Like Placido Best, the machine would be good enough, and the Topa is very good, TMS4. Even the Shin Nippon is cheap and good enough to start. I thought this would be a common question that beginners would like to ask. So our next eminent speaker, Dr. J.K. Reddy sir, Director, Kera Ectasia Hospital, Coimbatore, with a talk on recent advances on keratoconus in the management of keratoconus. Is there anything new apart from collagen cross-linking and DAL? Sir.
Thank you very much. I'm audible,
Yes, sir.
Yeah, for Dr. Anita for inviting me for this talk. And keratoconus, is there anything beyond collagen cross-linking with UVA and DAL in the management of keratoconus? Of course, we don't do DAL so frequently, but what are the other options in the surgical management, not optical? Today's stars are tomorrow's trouble. That is the problem with collagen cross-linking. So with the keratoconus symptoms, there are four aspects for us. One is prevention, whether we can prevent keratoconus, which cases we should aim to prevent keratoconus, for example. And early diagnosis, it became very, very important. And once you diagnose, how do you control progression and what are the treatment options? So here comes the cross-linking for one. Why cross-linking? Why you should look beyond cross-linking? For example, this patient is sick with a definite keratoconus, and this is post C3R, beautiful and flattening, very good vision. And after a few years, the flattening is progressing and progressing and progressing and progressing and became a irregular cornea with a loss of vision. Then put on back and contact. Of course, there is no ectasia, there is no progress. But flattening is progressing. The effect is more over a period of 5-7 years. It doesn't happen in every patient. It happens somewhere around 10% of the patients, or 10 to 20%, if you follow. So, what is the problem with the cross-linking? Cross-linking definitely strengthens the collagen in most of the cases. And the problem is, it's mild haze, it doesn't matter. It recovers in many cases, but few cases it permanently stays back. And cornea becomes a little bit irregular cornea surface in small percentage, say around 20% of cases. And main problem is it kills the keratocytes. If they repopulate, no problem. If there is no repopulation of keratocytes which were killed, then you have a problem of progressive flattening of the cornea and thinning of the cornea. Then what are the other agents available? It looks a very interesting agent, genipin. It is just a small chemical. It doesn't kill keratocytes, and it's a naturally occurring. It has been used in humans for a long time, especially in Japan. And there are many studies published, but of course, human trials have not started. We used it some 10-15 years back. This one very easy to mix. You have to mix in alcohol. It doesn't mix in water, so you have to mix in alcohol, then dilute it with BSS. So ultimately, 5% alcohol will be left behind, and 0.1 to 0.25%. And we did few cases, and it's worked well, more than 10, because of ethical and very complicated lab studies necessary. We aborted and shifted mainly to the now cross-linking with UVA. Otherwise, it's a wonderful technique of cross-linking cornea. Then comes the new one, the Rose Bengal with 532, which the advantage here is now used for infectious keratitis. This is also a same cross-linking. We need to find a laboratory evidence of cross-linking in vitro before we go for clinical studies. The advantage here is it doesn't kill keratocytes because it's just a 532 light. It's not anything toxic like UV. It doesn't kill keratocytes. That is a great advantage of this one when compared with cross-linking with UVA and riboflavin. And it's a very simple technique. The same parameters, same like UVA and riboflavin. Then coming to the keratoconus, we just think keratoconus is a disease of the cornea. We don't consider never a disease of the eye. I consider this is a collagen problem with the collagen somewhere, and it just affects the anterior portion of the eye. It's a keratoconus. It affects the posterior portion of the eye. The patient becomes a myopia, and it can involve both cornea and collagen problem. What is the basic problem? We don't know. That's a defective collagen, and patient becomes both keratoconus and myopic in axial length increase. So it clearly proves in MRI scans of myopia. Like keratoconus, we are seeing different apical, paracentral, central, different type of globus, over a period of time. Even a number of myopes shows a similar picture. No, we cannot map Kera with any device so easily. MRI shows the similar pictures like a cone, globus, eccentric cone, everything. So it's not different. It's both are same. One is affecting anteriorly, one is affecting posteriorly. This is basically as genetics were well covered by Dr. Revati. There is nothing point specifically which genes to look after. The environmental factor, yes, is very, very important. Eye rubbing, vitamin D3, essentially local inflammation. These are discussed very well. So coming to the one, the keratoconus or myopia, both are one and the same. Which part of the eye is affected by and which collagen, and a combination can also occur. So the eye rubbing has been very well discussed before, and with different patterns of rubbing produces different. It specifically shows which eye is affected more than the other eye. Sometimes it doesn't affect at all. One eye looks absolutely perfect. Seeing why they rub only one eye, why they don't rub, that's you cannot explain. That's their preference. One rubs right, one rubs left eye, and one sleeps like that and puts the pressure on the one eye, and one sleeps like that, put the pressure on both the eyes, and one puts a hand and sleeps and puts a bone against the eye, and they will have a terrible pressure, and some they put like this sleep. So the sleeping patterns are very important. So they produce a lot of pressure on the eye and can result in the collagen weakness and keratoconus. And you cannot ask this counsel this kid not to sleep like that. And the same problem, it's very difficult to prevent eye rubbing in a small kid. Anyway, so how do you prevent? And D3 looks like a very good option because more people are spending indoor times, more the incidence of not only keratoconus, more the incidence of myopia also. If you see the myopia incidence increase and the keratoconus increase, or both are on the same plot, they are not separated. The myopia is not standard. Myopia is also increasing progressively, the overall incidence and the higher powers, and the same keratoconus also increasing. So one common factor for everything looks like more spending indoor activities and affected from sunlight. Nobody wants to stand, and everybody covering their mostly in the shadows. So D3 looks like a very good option to start early in the life. And the counseling and screening of the affected children and parents. That's very, very important. If the parents comes with keratoconus, we have to screen them early and took all preventive measures like D3 supplements, eye rubbing, face down sleeping. All things should be taken care. And periodic examination and corneal topography. It doesn't. You should not feel shame to do topography more often in this, even though they look normal. Then the second thing is our own uh, uh, Balamurali Ambati has patented the copper sulfate. It's supposed to be a miracle medicine. They are still investigating. The copper sulfate drops, which works on the lungs and increases the activity of the lungs as a cofactor. So the cellular level, I do read, but not able to understand to that level. Dr. Rohit is authority on this in this group. So if they are trying, they want to see whether it's you need a lifelong use or a very long-term use or short-term use is good enough. Copper sulfate drops twice a day, increasing the LOX activity and reducing the incidence of progression. The other is the Bowman's layer transplant, on-lay or inlay. Then the Bowman's layer with the stroma, inlay transplant. This is what we are doing now and then. So we are we tried different lenticules thickness. Then ultimately we found that somewhere around 200 microns is good enough or less than 200. And the depth also we tried from 150 to 350, 400 microns. And deeper the depth is not that good results. Superficial is good enough for around 150, 200 microns. So 200 microns lenticule, 200, 150 microns depth looks like a good option right now. But adding cross-linking is not helping. Without, in fact, no cross-linking patients are doing much better with the implant than in our short series, than doing both procedures at a time. So we are cutting the right now lenticules with the microkeratome. We can do that with femto also. Both are almost same cost, a little bit few thousand, but somehow we started doing with microkeratome initially. This is the donor lenticule, and this is the femto pocket made in the patient. So 150 to 160 microns there, and we separate the pocket. all around. We make a large pocket, 9.3, whatever possible, but in that patient. It's quite easy to get separate this pocket and insert the lenticule into the pocket. So initially, what we did is we injected riboflavin also into the pocket and did cross-linking. They did very bad, few cases. The cases where we, and then we did surface cross-linking. Even they are not, they are okay, but not that even without cross-linking, nothing. Just put a lenticule and leave it. They are doing the best amount work. But very advanced cases, not much useful. Early cases, it's early means little bit advanced cases, not very advanced. There it is. This technique works very well, and they become very clear. It takes some time. It takes a month to 2 months to become clear cornea, except for the arcus. There it will be shown. And this is the OCT pictures. Initially, we cut thick lenticules around 400, 350 microns. Now we are cutting only 200 microns lenticules. So this is the parameters. Corneal thickness changes over a period of time when the lenticule becomes more compact and it becomes around 700, 600 microns cornea. So the topography also changes over a period of time. The cone disappears and it becomes more regular and a little bit the flattened cornea becomes steepened. For example, this blue becoming green and the red becoming a little bit yellowish and green. It takes some time. It takes almost 1 to 2 years, sometimes even 3, 4 years also. The changes keep on happening. What we learned in this technique is superficial replacement of the lenticule, better results. Thin lenticule, 200 microns, 1 is good enough. You don't need to put a very thick lenticule. And donor should be dried. If you cut a wet donor, it's very irregular surface. The donor should be dried by putting air in the artificial antechamber for 20-30 minutes. A dry donor is giving a very good uniform cut and nice lenticule. And the topography visual changes occur over a period. It takes 4 to 5 years also sometimes. Earlier done, better the results than waiting for a long time. Another thing that we are planning is we are planning a first few months of orthokeratology. Still, we didn't do any case. We want to put a lenticule and do a orthokeratology combined so that to give a good shape to the cornea and want to see whether that will improve the postoperative flattening much faster. So the corneal ectasia, when it comes to what is the problem, it looks like the defective collagen synthesis by a defective keratophytes. So it looks like the mesenchymal keratophytes are the culprit. The donor lenticules are divided of mesenchymal cells, so the pathology is not addressed here. We are trying to repair the anatomy, so it looks like even with the technique we are going in the wrong direction. So this looks like another very interesting study going on where human adipose-derived stem cells are implanted into the stromal pocket with a femto. It looks like a very promising technology, though the results are we have to wait and watch for a long time. And keratoconus is a very progression condition. It's not like all or none. All patients with keratoconus will not progress. Once you diagnose and caution them and take all the measures, many will stop progression. That is the big problem in these cases. So to do a controlled study whether it is effective or not. So they are trying two types. One is just injecting the mesenchymal stromal cells, and second one is a decellularized human donor cornea, again repopulated with recellularized with human adipose-derived adult stem cells, then an implanter. So this looks like a very promising technology for the future cases, early to moderate to severe cases. Then coming to the pathology, these insects are blamed for many reasons for collagen disorders in the progressive increase in the collagen. The insects is there are two ways. One is the direct toxicity of the insects. So that but it looks like you don't take so many daily prostaglandin inhibitors for a day on daily basis. So it looks like the other method of a mechanism is for everything a growth hormone is necessary for reparative process in the body. So there is an injury or there is insult or the pain. These are the stimulus for the growth hormone release or increase level. So once you suppress that inflammation and pain and everything and trying to take care, you don't land up in pain, you don't injure yourself, the growth hormone spots will be reduced and So that decreases the repetitive process and collagen synthesis in the entire body. So we cannot take keratoconus as isolated corneal disorders. You have to take it as a generalized phenomena affecting every part of the body. So then associated with that, as we discussed before, the lack of sunlight and deep deficiency became very common in most of the people. And the increase in screen time for IT candidates, we don't know how it's going to affect, but most of the IT people, they're landed with ketoconus, family foods, even at the later age. So the vaccine haters, they blame vaccines for everything in US. And childhood obesity is another big factor because they don't move. Once they're obese, they start moving and they become more obese. And decreased outdoor activity is definitely associated with. So how do you take care? So the early diagnosis, as we pointed out in one, and topical lubricants for IT people, and the topical cyclosporin drop to take care of ocular surface inflammation, and starting on vitamin D supplements early in the life, and encouraging them for a more outdoor activity. So they stay outdoors. It's not the question of doing strenuous exercise indoor. We have a lot of people who are going to the gym regularly. The terrible keratoconus they came after a few years. On. So it's outdoor activity that's essential. It's not the physical activity. And of course, collagen cross-linking. How do you cross-link it? That doesn't answer the pathology. Thank you very much.
Thank you, sir. It is not always a big problem. It is a combination of small problems. So we have to look for the small things or routine habits while we are treating the patient. And it is not always the C3R or DAL. Thank you, sir, for that miraculous video of persisted stromal enhancement and for giving us an insight into all the things we can do in our clinical practice. And also to know that we should treat the basic pathology and not support or try to repair the anatomy. Thank you, sir, for many take-home points. I would like to ask other panelists and chairpersons for their inputs or any other procedure in the keratoconus they are doing. We would like to know. Radhika madam, Revati madam.
Yes, Aditya, like I always listening to Reddy is, it's like, watching a very thriller movie, something kind of that. Always he'll come up with some new, new ideas. Really, I always look forward to it as usual, like, no. And the other thing is his candid acceptance, like, no, the stromal thing. Yes, we are addressing only the anatomy. This may not be the right direction that we have to look for another other ways also. But still, it seems like a stromal enhancement, even the Bowman's membrane or Bowman's with stromal enhancement, these things are seems to be working in if we are very careful about selection and know the technique, how to do it and all, as Reddy put it. But at the same time, they may not give immediate visual results or anything to the patient like DALK or PKP. So that has to be, the patients have to be counseled about that very clearly. Maybe we can retard the progression, as in the case of C3R, in cases, in some of these cases. Maybe that's what I understood from your thing, Dr. Reddy. What do you say? Do you use them as a optical treatment choice, or mainly to address the progression, where you, like, sometimes you cannot go for C3R or some other reason?
Not only now C3R, even patients are suitable for C3R if the surface suitability is more. It's making surface a little bit better. So we did some mistakes selecting a very good cornea and deeper pockets. So and combining C3R with the implant. So so we are more optimistic now. The problem is the donor corneas. So that became a big issue now. So that's why we are going a little bit slow. But otherwise, it looks like a moderate cases, not very mild. Mild cases can be gone for C3R. Moderate cases, it looks like this is the best option. Very advanced case, of course, DALK is the best option for visual rehabilitation. This is relatively easy technique in the hands of anybody can do it. Like DALK is a little bit and prolonged follow-up. If somebody comes from Saudi Arabia, somewhere, it needs a good follow-up in the case of dal, suturing or everything. Here it's not, if they're, it's a fairly short, very short follow-up. So we want to try orthokeratology with that and see whether the flattening producer will stay back a few months. That's a few things we want to plan to talk.
So there is one question in the chat box, like what is the minimum thickness for the bone transplant that would be required? Would you like to answer, sir?
Recipient, anything above 350 is good enough. Because beyond that, usually you will have a very steep corneas, which are very advanced, which fit into the dog. Before the dog, meaning 670s, K readings or all, there's no point. We did few cases like advanced VKC cases where ocular surface stem cell deficiency, where once you do dog, you'll end up in postoperative epithelial defect problems and all issues. So those cases we did, but not very good results. So around 350 to 400 is good enough. And the stroma, you don't worry about too much thickness of stroma. 150, 200 microns is best results.
Thank you, sir. We have another question in the audience chat box, like supplement of vitamin C, how much it works, like how do we have to prescribe, or it doesn't have a role?
Yes, to answer, because we don't supplement usually.
Okay, sir.
Sir, another question to you. I would like to ask a question. What about the stromal enhancement procedures for PMD, sir? Whether we have to take, we can try a large size stroma lenticle for those patients.
PMD, I put only the lower segment only, a crescent shaped one, I make a tunnel into the PMD area and put it. If the PMD is refractable up to 618 or 612, if you can refract the patient, even with the 18, 16, 12 diopter subcylinder also, doesn't matter. Even with 12 diopter cylinder, we are able to refract up to 618. I put into the stromal pocket. Then we custom design a phakic intraocular lens for them, and we implant. Because ICL doesn't give more than 5 cylinder. The Indian companies, they manufacture up to 8, 9 cylinder, 12 also. So remaining 1 or 2 diopters we can correct with spectacles. That's how we do it. But if only into the pocket, only into the inferior zone only, we put the lamellar pocket. We don't put full cornea in PMD.
Sir, that age-old procedure like the wedge resection. Sir, anyone is still doing that? Whether it's how is the results?
Dr. Kera was doing. I think Dr. MS was doing. I think now he's not doing. I did few cases before, long time back. Then it's a very difficult, I mean, very challenging. You should have a very artistic free hand to cut like that. Some defines are all marking, doesn't work well. We go by mechanics, by using the defines. So you have a free hand, it works very well. You got artistic hand, you can draw lines with a knife, it works very well.
Thank you, sir. Revati ma'am, your inputs regarding the wedge resection techniques.
Yeah, that's what I told even before, like MSR used to do. And I have tried a very long back I tried in 1 or 2 cases, but I didn't get as good results as MSR's thing. What he used to get amazing, even to look at it, it looks, as Reddy said, very artistic. And Srinivas Kera, a few weeks back in a meeting, he showed that, a meeting conducted by Shankara, he showed that he just showed his results, and he said he's getting reasonably good results, but he is very selective about the patients. And I tried what as Reddy do, like tuck-in. I tried putting a stromal layer like a DALK only in the thinned area and suture. It is not direct end-to-end suture. It's like a kind of mattress suture. I tried in few patients, and that is reasonably, as I said, you you become better with cases, more and more cases, and you can do. Sometimes in very few cases, I tried very advanced ones. So again, we have to find out our own techniques for these patients to address. They are not the regular keratoconus or keratoglobus in a way easier because all over it's thin. So like epikeratofakia or tuck-in, you can go ahead relatively easy. Addressing a localized thinning like PMD. And as Reddy said, sometimes it may appear in the slit lamp only in the inferior part. But if you carefully, especially look at the topo, it will be like on both sides, it will go. Temporal and nasal also, it will extend and it will be almost like a annular later it will become. So it's not so easy, the PMD to, the center thickness will be better, center will be flat, only the periphery will be a challenge for us.
Yes, ma'am.
Thank you, everyone. Thank you for all the inputs, like how to tailor the management as per the individual case. We would like to go out to our next talk. One of the dreadful nightmares to the refractive surgeon is post-LASIK ectasia, which is our next topic by none other than Dr. Rohit Shetty sir, Vice Chairman Narayan Nethalaya, Bangalore, a well-known refractive surgeon, as we all know. We have a pre-recorded presentation. We will start the video now.
Thank you, Team Aravind from Tirunelveli, for conducting this unique and very exciting talk and meeting on keratoconus. And thanks for giving me this opportunity to speak on handling post-LASIK ectasia, unpleasant scenario, extremely unpleasant scenario for a refractive surgeon. These are my financial interests. When you look at post-LASIK ectasias, we are looking at an incidence of 0.013 to 0.0935%. This is from the published reports. The reported incidence of post-ectasia is very low in PRK, and SMILE, the numbers and the duration of follow-up now is not reached that 10-12 years period, so still we are saving around 0.01%. The rate of ectasia in LASIK is 4.5 times higher in LASIK than PRK, and we still don't know the right incidence of it in SMILE. Let's look at what are the things which can actually help to reduce ectasia, prevent ectasia. One of the things is corneal topographers. We all know there are different types of topographers here. The OpScan, the Galilei, Cirrus, and all of them have their own indices. And none of them are perfect. None of them are foolproof. So you still have a completely normal indices and still you may get an ectasia. But still, this is better than nothing. So, the modern day topographers have all these mathematical driven indices, which still has a huge impact in preventing them. The biomechanics, the new Corvus from Oculus has a lot of new features. Features of new screening and a combination of Pentacam versus the Corvus. He comes out with two maps, the CVI and the TBI maps, which has a huge amount of sensitivity and specificity in detecting early ectasias, which could probably go into become a full-blown ectasia post-surgery. Epithelial mapping has been a very important factor which helps to understand the area of how epithelium changes with the area of cone, and this is probably one of the very certain markers of ectasias, and this can be incorporated into your clinics. What I'm going to bring to you is a completely new dimension of imaging called polarization sensitivity. The collagen of your cornea has a polarization property, and if you using that polarization property, you can image the collagen. When you're imaging the collagen, it helps to tell us the structure, the strength, indirect strength of the cornea itself. And using the birefringence principle of polarization sensitive light, we're able to bring in these kind of structural changes of the collagen. For example, this is how an ultrastructural collagen looks. And the darker shades of blue are more tighter collagen, and the peripheral fibers are represented in red here, as you see in this picture. So in your normal areas, this is how it looks. And then from first keratoconus, you can see that the darker blue has become lighter, and this area has lost that polarization birefringence properties. And in a keratoconus, is completely loss of orientation and alignment of collagen. So it helps this tool which we have developed not only helps to understand how a collagen structure is, it also helps to understand the whole properties of the collagen in a particular cornea based on type of corneas you see. For example, this looks a little suspicious on topography, but the collagen is normal. But in this case, this looks quite normal bow tie pattern, but you see a very poor collagen. So these could be the reason why we get unfavorable outcome as far as ectasia is concerned. And when we actually did an imaging of all the post-LASIK ectasia, which was referred to us, you can see that each and every cornea had a different types of signature in it. So using the AI, we also started looking at the prediction model for ectasia. These prediction models of ectasia is based on a mathematical driven finite element modeling, and these modeling are used to predict how the cornea would behave, and it would simulate the surgery even before you actually go and do a procedures. And this is what it is, and it can help to reduce the risk of ectasia. So from a topography, from a biomechanics, from an epithelial mapping, from an advanced imaging like polarization OCT, and an AI-driven mathematical modeling, you can all help in preventing that 0.01% or less of ectasia is what we see in our clinical practice. This is just a paper of us. The dotted lines and the straight lines represents how this collagen, how the post-operative state of your cornea is, and how your machine, the software, is actually predicting. The second most important thing in understanding ectasia is how the wound heals. And that is how a cornea heals. There are waves of healing, and you can see that the first wave of healing is always the pro-inflammatory. Pro-inflammation helps the cornea to respond to a particular insult, and the pro-fibrotic is where your keratocytes in your cornea, once you make a cut or do a laser, how the keratocytes becomes myofibroblasts, and afterwards how it remodels like this in this case. When there's a lot of inflammation in your eye, in your ocular surface, this pro-inflammatory phase keeps increasing. That means instead of coming down, it keeps increasing more and more. And these inflammatory molecules are the ones who probably has a huge impact in how the wound heals. And you can see that the corneal nerves here from pre-op to post-op is very poor. And these 3 waves of healing, what you see, just does not become 3 waves, and you can continuously this keeps going. And these changes on your collagen would have a huge impact in extracellular matter remodeling, and this has an impact in post-LASIK ectasia. This is a paper which we published where the corneal nerves were not healed properly even after 5-10 years after post-LASIK ectasia. And we did some work on the tear film biomarkers, and we found that there were a lot of molecular signatures which were very high, which were actually causing these kind of changes happening on the corneal ocular surface and the cornea. And also, it is very important that when you have these changes happening, especially in a person who has a genetic link to causing ectasia, then you can end up in having ectasia even with a perfectly normal topography. This is a paper, one of the first papers which we published, where we had a corneal lenticule which was stored in 2014, and 2018 the patient developed a post-smile ectasia. And when we went back and we took those lenticule, we found a gene which was defective in those lenticule called lysyl oxidase. And this is the world's first report on post-LASIK ectasia related to genes. And what are these lysyl oxidase? Lysyl oxidase are enzymes which bind the collagen like tightly, like, you know, it like holds the collagen tightly. And because it holds collagen tightly, it doesn't allow it to slip. So when your lysyl oxidase is weaker and it is induced by inflammation, the collagen starts moving out. So it always has to be held tightly, and that is its job. And that is a very important enzyme for the corneal structure. And what we found in this was that lysyl oxidase itself was genetically defect. So the collagen, even though the cornea looks normal on a topography, the lysyl oxidase was poor. So what happened? The cornea started bulging out and it caused ectasia. So how do you prove that inflammation is actually a driving factor? You know, how do you prove that this slide, what I showed here, is actually an important factor which causes changes on your lysyl oxidase? So what we did is we recreated this experiment in a lab when we actually induce inflammation on a human epithelial cell lines. And once you induce the inflammation, what we found was as the inflammation increased, the lysyl oxidase, which is those ones which holds your collagen, actually became weaker. Very clear example showing that there is inflammation. Inflammation drives eye rubbing, and eye rubbing drives loss of collagen here. All these things are linked to each other. So it's something which is very important. And so what happens here is that this same kind of inflammation has a huge impact also in understanding the PRK, because if there's more number of inflammation, you end up in having more number of haze compared to a normal healing when your inflammation is less. Now, what do we do with this inflammation? How do you actually measure it? In our laboratory, we used to take the tear film, take it to the lab, use proteomic, metabolomics, and other kinds of exercises. But now we have developed a point of care diagnostic kit, which you can use the kit on your. It's a small chip. You know, this chip can help you to look at all these molecules which have a huge impact on the outcome of your procedures, and which may cause an ectasia. So if these molecules are on higher, then you can probably look at different types of molecules, the tear film molecules like trohelose or liftigras or cyclosporin, and you can see that based on what you have, you can actually use, based on if it's higher or lower, you can use these molecules to actually block them and bring them change. So what is important here is that you have to bring in a very good diagnostics. You have to understand a proper wound healing, and you have to use all the modern day technologies to find solution for those cases who would become ectasia without a reason. That is something which is very important. This is one of those few papers which speaks about it. So ocular surface hygiene or ocular surface management is a very important stage when you have even a doubt about ectasias. And we could use a lot of treatments now from lubricants, omega-3 fatty acids, anti-inflammatory immunomodulators, and also LipiFlow, iLight or EI kind of procedures. Now, how do we manage it? What's the most ideal procedure? So you have initially you can look at your glasses or contact lenses, cross-linking, wonderful way of looking at it. And now you have Intacts and ICLs, and for most of those patients who you want them to see very clearly, you get an option of scleral contact lenses. So what are the ways we look at the managing the post-LASIK ectasia? We have a laser-based approach, the ring approach, and the phakic lens approach. And these are some small graphics about how we decide on what type of a procedure we want to follow. For example, if the patient age is more than 30 years, it's a contact lens intolerant. It's a very important thing. The flap thickness is very important, see, because you have to look at what are the flap thickness here. Because if the flap thickness is more than 120 microns, you have a high level of coma, you have a higher order RMS is higher, then you have an option of doing a simple topo-guided treatment where you can do a zero ablation. Zero ablation just takes care of, like in this case, a lot of irregularities. The whole idea is not to just knock the cornea off with refractive error. The whole idea is to make the cornea more regular. And we also have an option now, if the patient age is less than 30 years and their Pachy is less, but your abrasions are higher, you have an option of what is called as a TREC. I'll just discuss with you. This is an example of laser-based procedures. You can see that the patient has improved drastically, and his quality of vision has improved. And this is the number of patients we have done this procedure, and you can see the changes what's happened. TREC is a procedure what we use on Schwinn platform, where you can just make the just do a more of a PTK of a cone. It's like shaving of the cone, and we just do around 10-15 microns over and above the epithelium. That means if the epithelium there is 50, I do shaving of around 70 microns. And what happens is you get a huge improvement in the way the cornea reshapes itself. You can see that the cornea is like this, and you can see that this is the difference map, and -6, -4 power has become -3 cylinder. You can see just by shaving off that cone of around 10-15 microns, because it remodels itself and it creates this amount of a change. It's very important that this helps in understanding the how the cornea would remodel when you give a treatment. When you see a very steep cornea and the corneal thickness is not great, and the patient has a high level of astigmatism, then Intacs would be one of the procedures. When you do an Intacs rings, like in this case, putting a single ring here would make the cornea more regular, and it will make the cornea more flatter. So it's important that Intacs has a huge role in patients who are not really suitable for laser-based procedures or just a cross-linking. And for example, in this case, you can see that its flap thickness is more, less than 30. Epithelium pachymetry is very low. It's a decentered cone, but patient has a huge amount of coma and higher order aberrations. And this is one of those places where you can put a single ring and you can try, and you probably can get results like this. This is a single ring thing, and you can see that in this group 2, where you are seen when you put an Intacs rings, I think it's worked wonderfully well. So this is one of those indications. And then you see a central cone, you can do a cross-linking. All of them needs cross-linking, but we're trying to see how we can improve the quality of vision. And you can see this is the phakic lenses, how a lot of them have become completely emmetropic post this surgery. So what is important here is post-LASIK ectasia patients have undergone a procedure to improve the quality of vision. If you don't give them the quality of vision what they want post-surgery, they'll be completely unhappy. So you have option of cross-linking, but you can option of mixing cross-linking with lasers, or you have an option of mixing cross-linking with phakic lenses or with Intacs, which also has a huge role in the post-LASIK ectasia management. Please understand the role of pre-op imaging, abnormal wound healing, and ocular surface is very important. And you have to manage the ocular surface before you do anything. And the future is about customized therapies and customized investigations like PSOCT, polarization OCT, or the biomarker kit. So remember one thing, and in the procedure to manage it, use the of laser, cross-linking, Intacs, phakic IOLs. And all these procedures are very important in how you plan it. And one of the most important thing I look at it is the flap thickness. If the flap thickness is more than 150, laser does very well. If it's less than 120, 110, then you need to think about an Intacs or putting lenses inside. I thank my team, and thank you, Aravind, for this wonderful opportunity. I'm open for questions.
Thank you, sir. That was more of a futuristic tour of the options available in front of us. whether it like let it be the refractive surgery, post-op simulation, or a polarization sensitive OCT. Too many new things to learn, sir. Thank you for a ecstatic trek journey. Would like to take questions.
Thank you. Yes,
Thank you.
please.
Thank you for joining us, sir. Sir, the trek you said, that procedure of removal of the epithelium. So what is the mechanism, sir? Whether the new epithelium which forms is going to improve the...
No, it's not just removing the epithelium there. We look at the cone area and using only Schwind platform at this point of time, you can decenter the laser ablation to the area of cone. And we use the PTK of the epithelium with 10 to 15 microns of the stroma. When you do that, it shaves the cone off. And we just analyzed our 6 years data of more than 150, 200, I think, odd patients. And everybody has remained very stable. All of them have improved visual acuity by 30 to 40%. Quality of vision has improved just by shaving off that 10, 12 microns, and not a single one has progressed. Unfortunately, at this point of time, Schwind is the only one which allows you to change the pattern, change the laser to the area where you want.
It's amazing results. It's very nice to see that. And how many months you will wait for phakic IOLs after doing CXL?
6 to 8, 12, 6 to 9 months, up to a year sometimes. Okay. If your topography is changing between 2 visits, 3 months apart, then wait till it becomes stable. 3 months apart, it should remain stable, both the topography and your refraction. So that is your benchmark.
Yes, sir. Seema, you wanted to ask something? Some questions.
Hello, am I audible?
Yeah.
Yes, welcome to the Aravind platform, sir. We're very happy to have you. My question, two questions actually. Regarding trek, as you mentioned, you shave off the cone and a little beyond, little posterior to the cone, the stroma, and you combine it with the cross-linking.
Yeah.
Now, when you do the cross-PCOD, when you combine it with the cross-linking, do you remove the epithelium from the surrounding cornea, completely de-epithelize the cornea as in the regular cross-linking, and then the area of the cone alone is going to get ablated like a PTK?
You do the ablation on the area of the cone. You can adjust your the amount of ablation, amount of area you want to take out, and I manually scrape it off. Technically, technically you can do on the Schwind also. You can do the paracentral area also can be only shaved off, but it's like a 2 procedures, so I don't do it and manually take it off. That would be good to go, because now my 100% of my procedures, close to around 1,000 odd procedures of cross-linking we do a year. Completely, I moved on to this in the last 4 to 5 years now. And I feel that it gives you a better quality of vision. It gives you a fantastic improvement in the quantity as well as the quality. So that's something which helps me. And your thickness, reduction of your thickness is around 15 to 18 microns, which is very minimal. And what I believe is when you do a controlled scarring on the cone area by using some laser of very low dose, low threshold burns, just around 5-10 microns, 10-15 microns of stromal burns. I think it induces a very organized subclinical scar kind of a picture. But that's what I see on the confocal microscopy. That itself may help in stabilizing the cone and not allowing it to progress. So because so far we've done around 4,500 of these procedures and not seen a single one which has progressed.
So this beyond you're doing this for the regular keratoconus as well as the post-LASIK?
Both. Of course, only thing is your flap thickness has to be more than 120 microns as documented on your OCT. If it's a very thin flap, then it's going to be a challenge.
Right. And the other thing is this PSOCT looks like a very promising, area where we can explore the quality of the collagen before, deciding for a refractive surgery. And you've studied all the inflammatory markers and the corneal nerve regeneration. Like you said, it's amazing that your research is trying to bring all this to the bedside or the clinic side, so that we can select the patients on probably on a stick test before selecting them for a LASIK. But till such time that these things become a routine in practice, maybe hopefully sooner than later. But till such time that do you really think that it would be worthwhile giving some baseline anti-inflammatory agents, to post-op patients for a longer time, like say a cyclosporin or something, post-LASIK anyway, because we don't know which are those patients who are going to.
See, basically what I do is if there's a lot of meibomian gland dysfunction, if there's a lot of meibomian gland loss, and if the patient has a contact lens intolerance for which he has done a LASIK surgery, or you see that the T-but is on a lower side, it's best to keep them on a cyclosporin for a longer time. It's everything, all your inflammation is driven by MMP9. And in the beginning, Dr. Revati ma'am mentioned about IL-2, interleukin-1, which is a receptors, which is a trigger factor for a lot of changes on your related to eye rubbing. So when you use these kind of medications like the cyclosporin, and I do use a lot of trehalose-based medication. Trehalose works on autophagy and reduces a lot of these markers, including the IL-1. So what happens is that's how you monitor them to stop rubbing or stop creating irritation. Even if you don't want an immunomodulator like cyclosporin, any trehalose-based drops can work on the IL-2 receptors. That's what was discussed by Revati ma'am in the beginning when she spoke about the genetic link and eye rubbing.
But this would be for those patients who are having some baseline, some symptoms or some investigation just suggestive of dryness. But those patients who don't have any dryness to begin with, we select them for LASIK. But like you said, the collagen is at fault and the inflammation is, taking a toll on the cornea. Those patients also, would they, even if there is no dryness as such, would it benefit by giving, say, cyclosporin?
No, for them, I think you can use I use a lot of, in this presentation, I did not put that slide. When we use the trehalose-based medications, when the inflammation stops and you can see a collagen getting better, the reorientation of collagen getting better. So that's a huge area of work of using just a lubricant with trehalose to make the collagen. So all patients may not need it. Use of trehalose in these trehalose-based lubricants will really help in reducing the inflammation. This is what I feel, and I've seen it showing a lot of good results as far as the collagen and PSOCT is concerned.
Right. Thank you. Thank you very much.
Thank you, sir. Thank you, madam. That was a very interesting discussion about all the new factors becoming. We would like to go to our next talk. I would like to call upon Dr. Anita, madam, Head of Department Corneal Refractive Services, Aravind Eye Hospital, Tirunelveli, for our next talk on differential diagnosis of corneal ectasia. Madam.
Thank you, Aditya. My talk is on differential diagnosis, Kera Ectasia. Let's solve the mystery of corneal killing disorders. The list of disorders under differential diagnosis of Kera Ectasia is quite long, and they are actually considered as an uncommon eye disorders, but now become common, characterized by bilateral, unilateral thinning of central, paracentral, or peripheral cornea. Etiology might be congenital, dystrophic, degenerative, inflammatory, or infectious. Many diagnostic modalities are coming up every day for early diagnosis of keratoconus. We have discussed quite a lot about this to stop the progression and for early visual rehabilitation. The anterior segment OCT and epithelial mapping has gained recently gained importance for early diagnosis of keratoconus and to differentiate it from the other forms of corneal ectasias. Advanced cases of keratoconus, they are easy to diagnose with clinical signs and other topo or tomographies. Is it really important to differentiate pellucid marginal degeneration, keratoconus, and keratoconus? because all are non-inflammatory ectatic diseases of cornea. They are similar in names, similar in clinical presentation, similar in pathogenesis, similar in treatment algorithm in early course of the disease. But the variations exist only in the phenotypic expression. But the differentiation is important because in the preoperative evaluation of refractive surgeries and for contact lens fitting. Of course, the management and prognosis of late disease differs in all the three conditions. In keratoconus, there is an apical thinning and protrusion. In pellucid marginal degeneration, there is an inferior thinning and superior protrusion. Keratoglobus has a diffuse generalized thinning and generalized protrusion. The conditions which come under the spectrum of suspect keratoconus include contact lens Warpage, atypical normal corneas with astigmatism, pseudokeratoconus, form frestate keratoconus, posterior keratoconus, subclinical keratoconus, mild cases, etc. They have to be differentiated from the normal. The confusions occur in differentiating these conditions in extremes of presentations like form frestate keratoconus, mild keratoconus, etc. The diagnosis is important of all these cases in refractive surgeries because they lack clinical signs and only irregular astigmatism exists in the topography without any major change in the refraction. It is important to differentiate from the normal astigmatism to avoid ectasia whenever LASIK is done. This is a case of a 20-year-old female who presented with us for pre-LASIK workup with a -1 diopter cylinder, -1 cylinder at 140 degree, 6/6 vision, and similar refraction in the right eye also. But she gave history of recent onset of refractive error. The anterior elevation, keratometric map, and the pachymetric map was appearing apparently normal, but the posterior map showed some subtle changes. Hence, we deferred surgery for that point of time. Later, patient presented to us after 2 years with frank keratoconus. The next condition, which is more commonly common differential diagnosis for a corneal ectasia, is pellucid marginal degeneration. There, the thinning occurs in the inferior 1 to 2 mm from the inferior limbus, and protrusion occurs superior to the thinning. The onset of the disease occurs in the 2nd or 5th decade, and the flattening of the superior cornea occurs in the topo at the 90-degree meridian. This is more difficult to fit with conventional contact lenses due to involvement of the large against the rule astigmatism. Hence, it has to be differentiated from other forms of corneal ectasias. And also, they are poor candidates for penetrating keratoplasty. Not only that, because of the large graft involved and increased risk of graft rejection, but also the large amount of astigmatism after surgery and difficulty in visual rehabilitation. This is a case of a map showing a crab claw pattern, early case of PMD in anterior segment OCT showing the inferior thin. The crab claw pattern on the topography is not the diagnostic sign of PMD. It can also be seen in keratoconus, and the term we call it as pellucid-like keratoconus. So this is then what is the telltale sign of the pellucid marginal degeneration? It is the Bell sign. The inferior thinning compared to the other zones of cornea, pachymetry map, is the Bell sign. So this sign is the telltale sign for diagnosing pellucid marginal degeneration compared to the crab claw pattern. This is another pentacam showing the kissing bird sign with a beautiful kissing bird sign with a Bell sign. So this is pellucid-like keratoconus map showing a crab claw pattern and also central thinning here. There is no Bell sign here. So this map is called PLK map. This is the right eye of the same patient showing the crop lap pattern and the central thinning. So PMD can occur without the kissing bird sign also, only with the Bell sign. So one important issue, as already we discussed, the cataract along with the pellucid marginal degeneration. It's a very difficult situation because the onset of this degeneration occurs mostly in the 40 or 50 decade. So the custom toric intraocular lenses are now being used to manage such conditions. Keratoglobus, it's the next type of corneal ectasia. It's a congenital condition involving generalized thinning of the cornea, especially in the periphery. It may have a normal corneal diameter or increased associated with the scleral thinning. This condition is quite often difficult to differentiate from globus keratoconus and the megalocornea. The importance lies in the contact lens, usage of the contact lens, because in keratoglobus, contact lens is not indicated because they are more prone for perforation or rupture. And hydrops is also rare. So the three conditions, megalocornea, keratoglobus, and advanced globus keratoconus, three conditions are often confusing. Megalocornea is a congenital one and non-progressive. Corneal diameter may be more than 12.5 mm. And keratoglobus also is a congenital condition, but a progressive disorder. Usually the corneal diameter may be normal or more than 12.5. Advanced globus keratoconus, the onset of disease occurs in puberty to adulthood. It's a progressive condition, and the corneal diameter may be normal, again, may be more than 12.5. So the difference lies in the corneal thickness map. In megalocornea, the thickness is either normal, or if at all there is a thinning, there will be a moderate and regular thinning from the periphery to the center. In keratoglobus, there is a global thinning, irregular, and thinning is greatest in the periphery. Advanced globus keratoconus, there is an asymmetric thinning, typically greater centrally. So this is a differentiation of these three conditions when looked at a closer sight. So this is a map showing globus keratoconus with the irregular thinning more in the center. This is a case of a megalocornea, one of our patients showing a regular thinning from the periphery to the center. The next condition is the posterior keratoconus. There is an increase in the curvature of only the entire posterior surface. Anterior surface may be normal, may have only irregular astigmatism, usually unilateral and non-progressive. Associations include choroidal and retinal sclerosis. Posterior keratoconus may later progress to a keratoconus, so has to be followed up. Post-LASIK ectasia, here it is being discussed in detail. The LASIK flap itself is functionally decoupled from the cornea and thus provides a minimum tensile strength, resulting in the weakening of the biomechanical strength. The thin corneas and low residual bed thickness from deep ablation of thicker flaps have the greater effect in reducing the biomechanical strength. This is a pre-LASIK op scan showing So was showing the apparently normal elevation maps and the keratometric and the pachymetry map in the right eye. The left eye map showing subtle changes in the posterior map, having 54.4 posterior BFS, and the right eye also was showing 55 diopters. And the patient underwent LASIK. This was in 2007, and after that, patient developed ectasia, and patient underwent a C3R, and the amount of refractive error also reduced after C3R, and patient is comfortable with the spectacles now. This is another case, pre-LASIK map. Apparently, it looks normal, and with the central island here, and in 2014, and then patient developed ectasia later within 4 years. Terian's marginal degeneration is a degenerative condition wherein the thinning can occur either superiorly or inferiorly or circumferentially. It is always associated with a lipid deposition and vascularization, more prone for rupture. It's difficult to treat, and contact lens intolerance is more common with this condition. So many topography maps will be referred to us to rule out keratoconus. Like this case, there was a irregularity in everywhere in the elevation, curvature, thickness maps. There is a localized thinning here. So this is like a confusing picture whether to rule out ectasia or not. So we have to clinically correlate these conditions, wherein there was a corneal scar with ectasia here. And the topography is correspondingly, the topography has come like this. So pseudo-ectasias. Pseudo-ectasias are the corneas without ectasia, but showing some abnormal topographic or abarometric pattern that is compatible with keratoconus. So contact lens warpage and tear film meniscus instabilities are two conditions which have the picture of abnormal topography similar to that of the keratoconus, and we have to look at it at a closer view to rule out with true ectasia in these cases. So the tips include looking at the composite integrated information of coincidence of the highest, thinnest, and the steepest points on the elevation, pachymetry, and curvature maps, which helps the diagnosis of the pseudoectasia from the true ectasias. Another point is that in pseudokeratoconus, the numerical value in the elevation map, which corresponds to the steepened area of the axial map. So that map will show negative numbers or a depressed areas in pseudokeratoconus, which will be like this will be opposite. Like in keratoconus, the numerical value in the elevation map corresponding to the steepened area in the axial map will show an island of positive values surrounded by areas of negative numbers. So another point of differentiation is the pachymetry map, which shows a focal thinning in keratoconus, but not in the corneal contact lens warpage. So these are the differentiating tips by which you can differentiate the contact lens warpage from that of the true keratoconus. This is another condition often mentioned in textbooks as a differential diagnosis of corneal ectasia. They also can show a crab claw pattern, but this has to be clinically correlated because often this pictures they will like referred from the general units after taking an OB scan for the high astigmatism. They will present with the crab claw pattern like this, and the corresponding clinical picture is like this. There is an extreme. It's the case of a healed Moran's ulcer showing an thinning in the extreme periphery. Furrow degeneration, again, it is seen in elderly patients, a non-progressive corneal thinning, usually an incidental finding on the slit lamp, seen in elderly patients, a circumferential thinning limited to the lucid interval located between the limbus and the corneal arcus in each eye. Sorry for the poor picture quality. This is the case of a corneal steepening, diffuse corneal steepening, which was referred from some other hospital to rule out keratoconus to us. So this case, patient had a thick pachymetry map, and hence the specular and on closer clinical examination, the posterior polymorphous corneal dystrophy was diagnosed. The posterior polymorphous corneal dystrophy has been classified under ectatic disorder because of the associated significant corneal steepening in this condition. So steep corneas are identified in 37% of cases of PPCD and 86% of affected individuals with PPCD secondary to ZEP1 mutations. So often the keratoconus and Fuchs endothelial dystrophy, they coexist. These are the two conditions, like and it is difficult to treat which condition to treat first. All those confusion exists in these both conditions. So keratoconus in a Fuchs dystrophy may have a thick pachy, but with a steepening in the axial or the sagittal curvature map. So whichever condition is progressing among the two has to be treated first. Like if the keratoconus is progressing, treat the keratoconus with the CXF, and if Fuchs dystrophy, then Fuchs dystrophy has to be treated with DSEC or DMEC. So there are so many controversies in managing these two conditions. This is another case wherein 30-year-old female who was referred to us to rule out keratoconus due to the high cylinders, -4 in right eye and -3 in the left eye. Topography was normal, but the sheen flag images showed a tilted lens. On dilatation, there was a lenticular coloboma here. So the tilted lens also can cause high astigmatism and give you a picture of a keratoconus. So these are conditions which has to be clinically correlated. Thank you. It is okay to be confused because it is the first step towards clarity, and clarity would eliminate options and align with values. Thank you for patient listening.
Thank you, ma'am. That was a great overview to clear the confusions and giving us an array of conditions which we should look for while seeing pentacam or while seeing the patients which are referred to us to rule out ectasia. We can ask the panelists for any other conditions we should look for or any other diagnostic confusions that may occur.
I think Anita covered. Yeah, yes, sir.
One thing that one can also consider is sometimes after keratoplasty, if one has oversized the graft, it happens if one has oversized in therapeutic PK, say by 0.75, or previously there was shallow anterior chamber corneoarthritic scar, sometimes it's oversized even by 1 millimeter. So technically, just to complete the list, there also you can have a steeper cornea.
Yes, ma'am.
And the one point what you mentioned, when somebody is having some endothelial issue, when they come for especially for refractive surgery, if you see the pachymetric goes in the about 600 and all, be very careful, especially if the cornea is little steeper. We always used to do the specular also in these patients and make sure that any endothelial issue is there or not. And in that case, sometimes we find something because cell count may be low for that age, or sometimes even small gutty you can see, or something else. Then such cases, either we offer only the surface procedure, or we would like to wait and observe how they evolve. That is also we have to keep in mind because sometimes it can be associated with endothelial problem. And the PMD, what you mentioned about PMD is it's also true. Like we have to be, we have to keep that in mind. The Desmond's changes in PMD and even the old DM tear, birth trauma. Sometimes, no, when they come later, when somebody does topo, sometimes they'll get totally confused. There is looking like a keratoconus or something. And there is a condition called posterior keratoconus. One of the stage of the Peters, Axenfeld, and this one. Only posterior keratoconus, only a part of excavation, a small localized excavation in the posterior surface, where the DM will not be there. It is replaced by fibrous tissue. It's a congenital condition, and you will have astigmatism, and the topo will appear like a keratoconus, and the patient will have amblyopia because it's a congenital condition. These conditions also we have to keep in mind while looking at this patient.
Thank you, madam. Thank you for your inputs. We would like to take a few questions from the audience, like how to differentiate between pre-op keratoconus, or is it a post-LASIK ectasia? How to differentiate between the two? Anyone from the panelists would like to take the question?
Can you repeat the question?
How to differentiate between the pre-op keratoconus, whether it was a pre-op keratoconus or post-refractive surgery developed post-LASIK ectasia? How to differentiate if it presents post-operatively? Was it clear, madam?
When you see a post-LASIK ectasia, whether we can differentiate whether the ectasia was present before surgery or not.
Yes, ma'am.
Unless you have the pre-operative details, it's very difficult to make out. That's what I'm thinking.
And another question we have is how to differentiate between furrow degeneration and Moran's keratopathy.
Moran's will be like ongoing inflammatory condition.
Yes.
Furrow will not be, there will not be any inflammation. It will be just a degenerative condition. Moran's will have typical edema, overhanging edges, all those things. Furrow will not have all those things.
Yes, ma'am.
A furrow will usually have, like you just have an area of translucent thinning, and you will find that the periphery of the cornea will not be really involved at all. Whereas, like Dr. Revati says, there will always be edema and inflammation will be present in the case of Moran's. Both those things, I mean, I think that the difference is very clear cut. The second thing is the furrow is not just a small area of involvement, it's quite large. Whereas Moran's, you can see it progressing slowly, symmetrically and all the way along the periphery. So that should not be a problem at all, I feel.
Yes, ma'am. With that note, we would like to go ahead.
One point I'd like to make
Yes,
regarding
yes.
what Dr. Anita had a beautiful presentation with a lot of clinical pictures and correlating with the topography maps. It was an excellent presentation, I thought. And it's just one thing which it's really a challenge is when we see quite a few of these patients with fuchs as well as keratoconus presenting. Many a times what I have seen is these fuchs and keratoconus combined patients, usually we find them at a later stage when they are probably in the cataract age group, and the keratoconus probably has not progressed much, or probably it's an abortive keratoconus, or the keratoconus has been completely missed and the patient has never thought about the keratoconus not come at an earlier age. But if there is the keratoconus which is progressing and the fuchs also simultaneously at a younger age, these patients have a poor endothelium, and doing a cross-linking in these eyes also over a poor endothelium may also be a risk factor, because technically with a poor endothelium, cross-linking the UV radiation can hamper the endothelial cells and also can push the cornea into a compromised state, can decompensate. So that would probably be actually a challenging condition, whether or not to cross-link these eyes if there is any obvious fuchs. Any such cases that you have dealt with, Dr. Anita ma'am?
Yes, Seema, we have treated one such patient, and after seeing the endothelial count and the cell density and the hexagonality, we proceeded with treating keratoconus with CXL. With the patient was having a thicker cornea, and we safely did the procedure CXL, and patient is stabilized in one eye now. Another eye we are just following up. And post-operatively, the endothelial count is also normal.
Great. So these fuchs having a thicker cornea might be a protective factor, in the C3RS.
The thing is, we have to definitely emphasize the progression of the KC, that over that period of the 6 months, we have to ascertain the progression, then we can proceed with the keratoconus. Maybe in few cases, the rest of it just will have a steep cornea with the epithelial edema. All those features are also confusing.
There was also one of the points that Dr. Radhika Tandon ma'am had mentioned during her talk, that there are these cases where you would do an anterior lamellar and a posterior lamellar on the same patient at a staged kind of stage situation. So is there, could ma'am probably tell us also regarding which cases you would like to do a penetrating keratoplasty as such versus doing a DALC with an endothelial keratoplasty at a later stage or something like that?
So, if you have a full thickness opacity, then you'll do a penetrating keratoplasty straight away. I am saying that if you have, supposing a patient where there's been a healed hydrops, there is a scar, you can do the DALC first, and then later on, if required, you can do the endothelial keratoplasty later on. So, you should not immediately proceed for a penetrating keratoplasty if there is only a localized scar, thinking that the endothelium is damaged. So if it's a localized scar, you will do a DALC, and if required later, one can do a endothelial keratoplasty. If you have an extensive scarring involving the endothelium as well, you can do a optical penetrating keratoplasty. And even
I can't answer those questions.
Even when you have healed hydrops, and if you have a scar involving the endothelium, Then also, you may avoid a big bubble DALC, as even Dr. Devati said. You can try visco dissection, manual DALC, and you can avoid that area. You can even sometimes leave a little nub of stroma in that area and do the dissection to the rest of the area. It's much better than having a perforation and converting. Earlier we were very like immediately we would convert to PK. Now even if you have a small micro perforation, we avoid that. We put an air bubble and try to tamponade it and try not to convert it into PK.
So unless there is a scar, you would still go for unless there is a significant scar, you would still go for a lamellar keratoplasty. It may be 2 lamellar keratoplasties,
yes,
but avoid a penetrating.
Yes, that's right.
Thank you.
If I ask you ask in this particular situation, keratoconus with the fugues, it's very rare for them to present for surgery for keratoconus as such. I mean keratoplasty as such, because the cornea will be thick, and these patients like we can manage, as Anita pointed out, if at all they are progressing, if they present in that age, we can go for C3R safely, because all that are not, we can't brand them as fugues at that stage. But if they come for corneal decompensation later, and if you find there is keratoconus also, as well we can go for a PK instead of a EK in those patients. But if the keratoconus part is not very bad, because they lived with that keratoconus till that time, if the irregularity is not that much, still you can go, I feel, for EK alone. Such a situation is very, very rare, as you put it, like doing a DALC for that condition first and doing a EK for that condition later. It's very, very rare.
Yes.
But the other part, what Radhika mentions about acute eye drop scar or a post TKP or something, I have done T DALC in AK condition, and later I have done EK alone for the failing endothelium later. That you can, it can be done.
Thank you. Thank you.
Thank you everyone for the inputs. That was a good session. We would like to go ahead with our case presentations. We have 4 case presentations from our cornea fellows. First, Dr. Kriti from Aravind Eye Hospital, Chennai. We have a pre-recorded presentation which will play now.
Good morning, everyone. Here we have a case of atypical ectasia as double trouble. Let's see what was the case. This story dates back to October 2013, when 13-year-old male child presented to one of our center with complaint of defective vision in both the eyes. His refraction in right eye was 624, which was corrected to 612 with minus 0.75 diopter sphere, minus 2 diopter cylinder at 20 degree. In the left eye, it was 618 part, which was corrected to 612 part with minus 0.75 diopter sphere, minus 3 diopter cylinder at 160 degree. Retinoscopy was showing seizure reflex. Slit lamp examination was showing pressure serine. So both the OPSCAN was done. Here is the OPSCAN images of both the eyes. Here we can see the central steep cornea with mild asymmetric bow tie and superior paracentral thinning and posterior float elevation. So diagnosis of both the keratoconus was made. Based on the age of the patient, refraction and topography, bilateral sequential C3R was done in late 2013. After that, patient was regularly followed up in the same center. Post C3R refraction topo was done at regular intervals, which was stable. Here we have 3 years post C3R OPSCAN, which was done in 2016, which was stable. Here is the pentagram of the right eye, which was done in 2019, 6 years post C3R. It was stable, showing no signs of progression. Now in October 2021, this was the first time when patient presented to our center as 21-year-old male for routine follow-up post C3R. Refraction was stable when we compared to the previous refraction. This is the slit lamp images of both the eyes. We can see post C3R stromal haze and pressure ring is there. But what surprising finding, we noted in the left eye that there was an inferior nasal band of thinning with bowing was there. In the left eye, we can note the beer belly appearance, which is typical for the pellucidal marginal degeneration. Here we can see beer belly appearance when you compare it to the right eye. So pentacam was done, right eye pentacam was stable, but left eye pentacam was showing some progression. So when we compare pentacam with the previous pentacam of 2019, here we can see there is a worsening of the pentacam astigmatism from 2.7 diopter to 5.7 diopter. Keratometry steepening from 53.1 diopter to 57.9 diopter. Both the ASOCT was done. In the right eye ASOCT, you can see some post-citherial stromal haze. Otherwise, it was okay. But in the left eye ASOCT, here we can see there is inferior nasal band of thinning and bowing is there. That elevation just above the area of thinning, which was correlating with our clinical findings. This is the ASOCT topo picture. Right eye was stable. But in the left eye, here we can see in the anterior sagittal curvature map, apart from the central area of steepening, there are some subtle changes noted in the periphery, which has become more prominent in the tangential anterior curvature map. In the tangential posterior curvature map, you can see there is an area of peripheral steepening which is separate from the central area of the elevation, which is typical of the pellucidal marginal degeneration. Thus, we concluded that this is the case of progression of keratoconus after 8 years following C3R with the new onset of PMCD and keratoconic eye. Keratoconus and PMCD can rarely coexist, but late appearance of PMCD in case of keratoconus after C3R treatment in young patient has not been described in literature yet. And tangential curvature maps are most sensitive of the power maps as they measure power and curvature at individual points on the cornea the most accurately. In our case, in view of peripheral thinning on ASOCT and pachymetry below 350 micron, we have avoided doing repeat cross-linking. Thank you.
Thank you, Dr. Kruti. That was a good presentation. Dr. Seema ma'am, any comments on this?
So basically, this case was very intriguing because for many years, this patient had a follow-up at another center, and when he came to us several years after cross-linking, clinically we found that the PMD was kind of staring at us. It was looking as if it was a PMD eye rather than a keratoconic eye to begin with. But when we did the pentacam as such, we did not find the pentacam significantly showing the changes of PMD that we would expect, and possibly that was because of the masking post C3R effect. So now that one of the last images that Kriti has shown was one of the very, very unusual pictures. If we could see that picture once again, where the tangential posterior curvature was actually showing us, very classically two separate areas. One was corroborating with the keratoconus, and the other was corroborating with the peripheral curvature also was shown very well. So this is to emphasize that sometimes we have to rely on our clinical, what we're seeing, that also. And apart from that, the tangential curvature maps give us, quite a bit of information as compared to axial curvature maps as well. So take home point being, we can have progression, and keratoconus and PMCD might be, different entities in the same spectrum of corneal ectasia. So we might have these entities coexisting as well. And it might surface up even after C3R, because the C3R was done at a very young age, 13, and a patient is still in the stage where, corneal ectasia is known to progress. So we found it as an interesting case to discuss. Any comments from the seniors?
Differential diagnosis. For differential diagnosis, you mentioned no. Tangential is better than axial in some.
Is it possible that you could have missed the PMD in the beginning? Because after all, PMD manifests much later. But I do agree that why would it have to manifest after C3R? But it's also true that the efficacy of T3R in PMD is not proven. So all these things are also there for you. So whether it is a missed PMD in the beginning or a mixed pattern right in the beginning or PMD evolving later is very difficult to say in this particular case.
Similar pictures you can see even in post keratoplasty in keratoconus, especially if you do a relatively smaller grafts, and years later they will come back with again kind of recurrence. But then when you see carefully, the thinning and ectasia will not occur within the graft area. It will be almost on the recipient area or on the graft host junction. So even high drops can occur in a post PKP. At that stage, it can from the graft host junction, a thinning and Desmet star can occur. I have seen such cases. So maybe some kind of a similar mechanism is going on here, but very surprising, around 21 years or something, this patient is presenting with a PMD-like picture in the periphery, because PMD usually we expect in a very later age. So this is a really interesting case, and Dr. Radhika, Dr. Reddy, we would like to hear your inputs also in this.
Some cases will come, madam, only when we pick it up. It's a clearly case of PMD. So central area has become, that clearly shows cross-linking works. But the problem is we are done only 8 millimeters, So the peripheral, there is no still collagen is not there. But the issue here is the PMD, why only comes in the lower portion, why not in the upper portion? So if you use protective, more cornea in the lower portion is exposed to the sunlight than in the upper portion is covered by the lids. So that brings the concept of the tears are the culprit for one concept, because the upper lid, under the upper lid cornea limbus is never, tear film is not that thick, whereas under the lower lid, lower portion, that tear film is quite high. If you have some collagenous activity there going on, then you will have a thinning of the cornea along the lower limbus. But the one funny thing is, the inflammatory markers, they say increased, but as usual, you might have seen a lot of our keratoconus cases, which they had if they had injury in one eye and inflammation has some injury in one eye, that eye will never progress, keratoconus. The other eye is, you have advanced keratoconus, you might have seen few cases where the small injury happened to the one eye with a scar, that they never get keratoconus, that will stop. So once in a while you see, once in 2 or 3 years a case. So inflammation within the cornea will stop keratoconus. Inflammation outside the cornea, tear film, ocular surface will increase the keratoconus incidence. So it's very tricky. Only we can interpret, put hypothetical solutions. But here is very difficult to manage. This as he's telling you, there is no point in doing second cross-linking in this patient, and it's very thin. Sometimes they perforate if you do cross-linking that area. In long time back, my fellows, when we are not doing much, all fellows were only doing 10 years, 20 years back. So they did like that. We had one case at least perforated where they did cross-linking.
This patient have BKC or something, or eye rubbing habit?
That's another issue. One eye.
This particular patient did not have, madam. This particular patient was not an allergic BKC patient. He was a young onset keratoconus patient.
BKC is absolute not necessary. Sometimes eye rubbing is just a habit.
Yes. Yes. Not a known eye rubber, not a known eye rubber.
Dr. Radhika?
Interestingly, generally, I haven't seen perlucid marginal degeneration that much in the younger age group. So maybe this patient was prone and had keratoconus, and the PMD manifested later on, because he first came with keratoconus at the age of 13, and already the symptoms were going on for a little bit longer. So I feel most probably at that time he may not have had the PMD, but it's all guesswork, as Dr. Reddy says. Generally, I find that people who come with PMD are a little bit older, whereas keratoconus you can get in much younger age group. But you really have to put all the data properly together and systematically analyze, otherwise it becomes anecdotal. But the important thing is the message is that every case you have to look, because now we know there are these associations. So every case of keratoconus, don't just be happy with the center, look very carefully for the periphery.
Thank you, ma'am. Thank you for this wonderful inputs, Dr. Radhika ma'am and Dr. J.K. Reddy, sir. We'll keep all those brilliant points in mind. Thank you.
That was an interesting case presentation and interesting discussion too. We'll go further on to the next case presentation by Dr. Rupa from Aravind Eye Hospital. Please share the presentation now. We will start the case presentation again.
This is Dr. Rupa. Today I am going to present a case report of keratoconus-like changes in stromal keratitis of a 16-year-old male patient present to our hospital with complaints of redness, blurring of vision since 1.5 months, not associated pain. Patient was referred from local ophthalmologist, treated with topical steroids, topical and oral antivirals since 1 month on the suspicion of viral keratitis. An examination, right eye uncorrected visual acuity was 6/36, improved to 6/9 with -1.5 cylinder. Left eye uncorrected visual acuity was 6/6. Slit lamp examination of right eye cornea shows diffuse deep corneal cellularity with mild stromal haze with few vessels. Corneal sensations were reduced. Left eye examination within normal limits. Confocal microscopy of right eye shows no evidence of cyst filaments, but shows only few inflammatory cells in deep stromal layers. Based on history and examination, clinically diagnosed as non-necrotizing stromal keratitis of presumed herpetic origin. The patient was treated with topical corticosteroids, topical and oral antivirals. During 1.5 years of follow-up, the patient relapse occurred with reduction of the therapy. Patient had past history of tuberculosis at the age of 4 and was treated. Now patient was investigated for Montox, which was negative. Chest X-ray shows prominent bronchovascular markings. Active infectious marker for tuberculosis, interferon gamma relay assay was negative. On few months of waning of the medical therapy, patient again present with us with complaint of redness and watering in both eyes. At this presentation, his right eye uncorrected visual acuity was 3/60 with no improvement, and left eye improved to 6/6 with -1.5 cylinder at 90-degree axis. On examination, left eye had few SCKs. Right eye cornea shows keratoconus-like features and deep stromal scar with vascularization and thinning. Treatment started with topical steroids with Sonjel and oral acyclovir. Left eye serial corneal topographs done. Parameters are within normal limits. Pentacam pachymetry, thinnest is 543 microns and thickest is 545 microns. Condition explained to patient the ectatic changes in right eye and was advised to use contact lens for right eye visual rehabilitation. In view of viral recurrence and chances of graft failure, surgical intervention was avoided. Patient was prescribed miniscleral contact lens for right eye and was comfortable with contact lens. Coming to discussion, the topographic changes due to infectious keratitis seems to depend on the location of the inflammation and the healing response of the host. The pathogenesis of these changes has not been elucidated, but the first pattern may be associated to stiffening of the inflamed cornea due to a predominance of scarring process, whereas the second keratoconus-like pattern would arise through stromal melting. Multiple studies reveal the importance of inflammation in the progression of the disease, and a recent consensus was to consider keratoconus an inflammatory disease. Our patient had past history of tuberculosis, but there is no evidence of present history of systemic disease and family history of keratoconus. He developed rapid keratoconus-like corneal changes in the eye with recurrent inflammatory manifestations, but no clinical signs of keratoconus in the other eye. This clinical case may support the essential role of inflammation in the development and progression of keratoconus-like ectasias. In conclusion, keratoconus-like changes can occur in young patients with recurrent interstitial keratitis. In this case, we didn't find the exact cause for corneal ectasia. These are my references. This is the photograph of patient after miniscleral contact lens fitting. This is pentacam of right eye. This is pentacam of left eye. Thank you.
Thank you, Dr. Rupa. That was a good case. I would like to ask opinion of Revati madam about the case.
Yes, we put this case mainly, like there was a question also, no, uniocular keratoconus kind of thing. We have seen this kind of deep vascularization, thinning, sometimes even lipid deposits, another one or two patients also, but it was not so prominent thinning and ectatic changes in other cases. But here in this case, he's a medical student at present. We started seeing him when he was in +1, +2 stage, and slowly he developed this thinning and ectasia. And even he went and met Dr. MS sir also once, and even he went to, I think, LVP to meet Dr. Sangwan or one of the consultants there. And if nobody could point out the exact reason, the presumed viral etiology, and this thinning, ectatic change. His father was my UG classmate. He's a pediatric, he's a surgeon now. He was also insisting whether we can go for keratoplasty or something. But everybody advised against surgical intervention because of an ongoing recurrent inflammatory changes, and the etiology is not very clear. But it didn't stop with a scar as a other viral keratitis. It started as a deep inflammation and started progressing as thinning and ectasia. So I would like to listen to Dr. Reddy, Dr. Radhika, and other centers, other consultants about their experience in similar cases.
Very rare. I don't remember. Maybe one or two cases we saw it irregular thinning, but they settled down. Viral keratitis, put on systemic steroids from congenital from age of 1 year, 2 years. They have chronic keratitis. Once you put up an ganciclovir topically, continuously, not stopping, they settled down. They didn't go for ectasia. There was some irregularity in the cornea surface, but they settled down, but not stopping. But how to confirm here is the problem. You have to do PCR of again biopsy or something. How to confirm it is herpes.
Yes, Radhika.
Yes, actually, sometimes people do use the term secondary keratoconus, where if they had a history of trauma, then there may be, ectasia. But I think technically the word keratoconus shouldn't be used with this. It should be said like secondary corneal ectasia. And in this case also, because if you see the basic pathology of what's happening is, there is inflammation, there's a breakdown of collagen, there's irregularity, there's thinning, and then sometimes you may have associated raised intraocular pressure. Like, for example, we have also found in patients with congenital glaucoma, when the pressures were not controlled, they were also getting features of some steepening and posterior elevations, which change when the pressure gets controlled. So, I mean, definitely it's something that people need to be aware of, and one could call them more like a secondary ectasia or related to the whole disease process. And confirmation of diagnosis, I feel that the sensations being low is indicative that it was most probably herpes. With CMV and all, barely you get the sensations low. And largely, I think your clinical assessment is absolutely fine. And such patients, they will benefit more from a PK than a DALC, though Donald Tan and his group have said that they would like to do lamellar keratoplasty in virtually every case, including viral keratitis, because if you're not aiming for absolutely crystal clear cornea and 6/6 vision, then even in such cases, you can get sometimes 6/18, 6/12 vision with the DALC. So that's just a question of, how you want to take the case. But usually we would go for penetrating keratoplasty if one has to operate on such a case. Because, we just want to give the patient quicker recovery. And cover with antivirals as well, and allow for at least 1 year quiet period without any recurrences in our scenario, basically.
That's why one reason why we hesitated to touch him at that very critical period of his life, going into the medical college, and still he was getting as soon as you taper the steroid, now and then some inflammation that and active vessels I could see. That's why, like, we postponed the surgery. Even I convinced him, like, we will wait.
Is his topical antivirals getting, madam? Topical antivirals.
He was on topical antiviral also. I think after
he's tapering, he's stopping.
Yeah, I think that it's very difficult because we don't know he like what this that age boys they will don't know. He might be stopping, and I feel like that because while talking to him, actually he got with all this going on, he got very good marks in NEET and just walked through and got a MMC seat. He was like an academically very accomplished boy, and his only problem was not even about his studies. His vision is he was asking, I am not able to play with the cataract lens on and all. I'm not able to play. That is his main complaint. He is not bothered about his academic performance. He could do it very well still. So maybe now he is in final year or something. After some time, I have to see him. If it remains quiet, maybe then I will think about a surgical intervention. And I would go for a PK, as Radhika pointed out. These cases I won't touch for a DALP.
Thank you, madam. That was a good presentation and valuable input from the experts. We have come to the end of the session. We would like to end with a small thanking note.
Yes, we have come to the end of this webinar. On behalf of Aravind Eye Hospital, Tirunelveli, we would like to thank the esteemed chairperson, Dr. M.S. Sir, for joining us and sharing his thoughts. We extend our thanks to Dr. Revati ma'am, the co-chair, and the eminent speakers who have made this webinar a successful one by sharing their surgical and practical experiences in corneal ectasias. I thank Dr. Radhika ma'am, J.K. Reddy sir, and Anita Raghavan ma'am for staying throughout the session. Thanks to all the panelists and delegates for making it more interactive and interesting. Last but not the least, thanks to our CMO, Dr. Meenakshi ma'am, and our advisor, Dr. R.K. sir, and IT department for a smooth run of this webinar. With the hope to have a physical meet next year, I thank everyone. Thank you.